Ready? Sound, mics off, please. Shri Gurubhyo Namaha. Namaste and welcome to this lovely afternoon. Myself, Dr. Malashri, PhD scholar, Department of Shalakyatantra, National Institute of Ayurveda, Jaipur. You are today's host and moderator of this session. Today, we, family of NIA, is very pleased to begin with a national webinar on thyroid disorders as a part of celebration of 7th National Ayurveda Day. With blessings of our patrons, Sri Sarbanan Sonowalji, Ministry of Ayush,
Scholar of Examination, BOS member of KLE University. Sir has been field visits to identify medicinal plants for UG and PG students. Sir has conducted more than 50 free thyroid camps where more than 3,000 patients have been benefited in past 5 years. Sir has published more than 10 international articles and has authored 3 books. Sir has been a resource person to more than 20 conferences and delegate in more than 30 national and international workshops. Till date, Sir has guided more than 10 postgraduate students. It is our honor to have you and to hear from you, Sir. Warm welcome from the organizing committee. Over to you, Dr. Malashri ma'am.
Thank you, Dr. Pratima, for this warm welcome and special introduction to our today's first guest lecture. Now I request Professor Arun Chogle sir to begin with the session. Sir.
Yeah. Okay.
Very good afternoon to you, sir.
Good afternoon.
Sir, you can proceed with the session, sir.
Yeah. So, yet you are not permitted for presentation here, please. Am I audible?
Sir, yes, sir.
Audible, sir.
Yeah. Now you are not allowed to share your screen, sir. Just please allow me to share my screen.
Sir, you are absolutely audible to us. Sir, your voice is clear. You are audible, sir, but the presentation slide is not visible on screen, sir. Kindly make settings for that, sir.
Sir, I am audible. Allow नहीं कर रहे ना. Madam.
Sir, any technical problem?
Yeah. You have to go for. आपको होस्ट करना है मुझे, क्योंकि शेयर स्क्रीन करने के लिए you have to send me some this one.
Yes, sir. Yes, sir. Give me 2 minutes, sir.
ऑलरेडी रिकॉर्ड कर रहे हैं, पूरा वीडियो बन रहा है.
किससे बनाइए मैं कौन आ रहा है?
Like you can just give your this thing brief to keep up. Just you can give some points highlighting about your practice or anything related to this disease, so that we can, by this time this is set right, you can just be speaking related to that.
Humble apologies for inconvenience caused from our side, sir. Sir, soon we'll be allowing for your presentation, sir. Your slides you can present.
Yeah.
को कहते हैं खेलने वाली, जब थोड़ा फल करते हैं ये सही है, परफेक्ट है, गुस्सा मत कर।
Sir, once again, humble apologies for the inconvenience caused from our side. Sir, you are allowed to present now. Sir, you can begin with, you can proceed with your presentations.
सर टॉस पे बहुत कुछ डिपेंड करेगा सर। हाँ, 2-5 बैटिंग वो जीतेगा बहुत ज्यादा। सर ये आगे वाली कितने वाली 5 ओवर कैसे पूरा सब पका के
Yes, thank you, sir. Over to you, sir.
मेरे को लग रहा है 11 हो जाएंगे क्या? अरे यार क्यों मेरा क्या हो गया पहले मैं तो आपको दोनों ही वैसे दोनों ही आगे आउट कर रहे हैं।
Am I audible?
Yes, sir, you are audible, sir. Clear.
Shall I start? Shall I start?
Yes, sir, please, sir. Please proceed, sir.
Yes,
Good afternoon, one and all. Myself, Dr. Arun Chavle. I am dedicating this presentation to my guru, respected late Sri Dr. Sri G. Srinivasa Acharya Sirji. With their blessings, I am here to present. I am here to present critical Ayurvedic views on thyroidism. Okay, we'll discuss one by one. Before that, being an Ayurvedic physician or Ayurvedic scholar, we should have some basic knowledge regarding glands. This is a one reference for ductless glands. This is an indirect reference from Charaka Siddhisthana, 9th chapter 4th sloka, where the simile is given that the sun rays moves directly from the sun to earth without any interfering channels. Same way, ductless glands secrete their hormones directly into bloodstream without any intermediate channels. This is the expert opinion from Vaidya Krishna Sharma Khandela. See, this is the most important reference for an Ayurvedic scholar as well as Ayurvedic physician to justify ourselves with respect to endocrinology. So, as the topic say goes like a critical views. So, I am having some critical Ayurvedic attention with respect to endocrinological system, where we define health as the cellular level three-dosic balance. This is the health with respect to endocrinological system. And the next point is it is related to Agni, where Agni is responsible for entire events of Paka. That's right. Almost all biological transformations and metabolic activity stabilization, they are correlated with the Agni. And the next is the Agni Vyapara. Whatever metabolism takes place in our body, those all metabolisms related to Agni Vyapara. That's right. In toto, the endocrine activities are nothing but they are the creations of three-doshic balance, Agni, its status as well as Agni. These all conclude endocrine activities. Look at the endocrine system for the basic information I want to give here. We are having major 9 glands that we have to screen with respect to endocrine system. So, what is the primary understanding of endocrine system at doshic level? At doshic level, our understanding should be concentrate on the doshic triad of prana, sadhaka, and avlambaka kapha. Although other types of doshas are involved in the endocrine system, but we are giving primary means paratvam, where prana mata controls most of the neuroendocrine functions. Sadhaka pitta is responsible for basic endocrine functions and overall kapha functions in the body. This is the primary understanding of endocrine functions at doshic level. Now, what are the critical views with respect to Dhatvagni? The Dhatvagni is similar to the functions of hormones, keep it in our mind, and BMR, basal metabolic rate, which is very important in today's discussion topic, where this BMR is regulated by Bhutagni and Dhatvagni. So Bhutagni, it works at the molecular level, and Dhatvagni Vyapara, it works at tissue level. So Bhutagni and Dhatvagni functions are very important to maintain BMR. Then, as usual, Vata dosha, Vata Yantra Tantra Daraha, or Vata Pitta Kapam Pittam Pangu, Kapam Pangu, Pangu Maladhatva. That's why we have to give utmost importance to Vata dosha because it controls Yantra Rupa Sharira as well as it controls Mana and Indriya. That's why these are some critical views with respect to endocrine system where Dhatvagni you may consider hormones, BMR is regulated by Bhutagni and Dhatvagni, and important dosha is Vata dosha for all types of Mana Indriya, psycho neuroendocrine functions. That's right. In total, it matters the perfect functional harmony of a psycho neuroendocrine system. When it matters, at that time you have to concentrate 4 factors. Those 4 factors are, the first one is an uninterrupted gati of vata. The second one is regulation of Shad Chakra. This second one is also important. You have to consider for psychoneuroendocrine system. The third one is balanced Agni and Agni Vyapara. The fourth one is normal function of Pitta and Kapha. These 4 factors matters for the perfection of harmony with respect to psychoneuroendocrine system. Keep it in mind. That's right. How the endocrine disorders manifest. Endocrine disorder manifest. The initial phase starts with impairment of Agni, followed by disturbed 3 dosha balance. Then involvement of all the 3 Roga Margas and results in multi-scrotus involvement. This is the chronological outcome with respect to endocrine disorders. So, my opinion is that if you analyze critically, we are having some speciality of endocrine disorder. What are those specialty? The specialty is in most of the endocrine disorders, involvement of all the 3 Roga Marga, not Bhahi, Madhyama, Antar. All the 3 Margas are involved. And there is a multi-scrotus involvement. These are the 2 unique speciality of endocrine disorders. That's why they always manifest as a syndrome, group of disease. These 3 Roga Marga and multi-scrotus involvement is very important from the point of treatment aspect. Now we come to critical view on Astau. This is the chapter by applying the inferences, Vidhi Vimarsha, where we are having only one chapter which tells something about genetic and neuroendocrinological disorders. This is applied inferences. What are the peculiarities of the disease or the conditions mentioned in this Ashtanindita Adhyaya? The peculiarities are All the diseases they are deep seated, having dhatugata stages with lesser amount of dhatu bala and dhatu sara, as well as having some potentiality with respect to bija dushti. And the second one is they signify grave medical situations. They signify grave medical situations. And the third one is complicated managing alternatives. So it is very difficult to manage. That's why they are. It is said that Ashtanindita. There may be a chance of losing name and fame if you want to treat Ashtanindita Vikar. It is that's why it is called as Ashtanindita. So these are the peculiarities of Ashtanindita Adhyaya. And Ashtanindita Adhyaya is only one chapter with applied inferences or vidhi vimarsha. We say that example for genetic neuroendocrinological disorders. Now come to the Medo Pradoshaja Vikar, Charaka Sutrasthana 28th chapter, where he said that Ashtaninditani Prameha Pura Rupani, accepted. So from the first year undergraduate up to completion of post graduation, we are taught by our teachers or by us also that Medasa as a fat tissue. Okay, if we accept Medasa as fat tissue, some extent we can justify Ashtanindita with respect to Atistula, Atikrusha, where there is involvement of Meda Dhatu and fat tissue accepted. But what about other conditions where Aloma, Dirga, Gaura conditions are there, where it is very difficult to justify the students with respect to Medas as fat tissue. That's why, according to Charaka, Medas is something different than fatty tissue that is highly applicable with respect to endocrine system. What is that? That is nothing but Medas with special reference to endocrinological disorder. As per my view, Prameya Rupani, Prameya Pura Rupani, we can consider the Medas as insulin hormone, and Ashtaninditani, the hormones of pituitary gland we consider as Medas. Otherwise, it is very difficult to justify Medo, Pradosha Vikara, Prameya Rupa, Prameya Pura Rupani, and Ashtaninditani. Okay, this is very important critical view with respect to Medas as per Charka. Now, come to the subject proper, that is thyroid disorders. So, the first and foremost important question is nomenclature, where it is mentioned, what is the name, etc., etc. So, basically, it is Anukta Vyadi. That's why we always consider this disease with respect to Trivida Bodhi Sangra, where we are only consider or worried about Vikara Prakriti of that condition or Adhisthana or Samuttana. Keeping these views, Trivida Bodhi Sangras, we are concentrating on Aturasya Vikara Poshamanam rather than naming the diseases. This is one factor I want to highlight here. Because exact correlation of hyper or hypothyroidism with specific thyroid disease is very difficult, because multi-system involvement mentioned from contemporary science. Sankara means group of disease or symptoms we observe in these conditions, but understanding becomes easy based on your Trivida Bodhyasana. So you have to concentrate on treating the diseased condition rather than naming the condition. This is the regular or common pathophysiological aspect of thyroid, where it is said that thyroid hormone production is under the control of hypothalamic TRH and pituitary TSH, but also iodine availability. Why I kept this explanation? Because in this explanation, I want to highlight two organs. The one organ is hypothalamus, the another organ is pituitary, where they are situated in brain. Okay, that's why when there is a involvement of brain, involvement of hypothalamus, pituitary gland, thyroid gland depicts as Urdhva Jatrugata Avayava. Initially, I kept this slide to give respect to Shalakyatantra department. They are because they are the host. Okay. So, if you screen the involvement of hypothalamus, pituitary gland, and thyroid gland, depicts Urdhva Jatrugata Avayava, and hypothalamus and pituitary gland depicts something about the brain, Shiras. Okay, that's why, which is the best Shodhana procedure. The best Shodhana procedure in almost all Urdhva Jatrugata Vikara is Nasya. It is said that Nasahi Shirsodhana. So, how we have to view, critically view this explanation in relation to Ayurveda? Come to this point. Okay, that information directly or indirectly give some inference regarding usage of nas and medhyadravya prayoga in the management of thyroid disorders. Okay, I will give you one example, few examples where in case of hypothyroidism disorders, the patients are more prone towards a tamasic lakshana. Those are hypoactivity. And in case of hyperthyroidism, the patients are more towards about Rajasic Lakshana with reference of hyperactivity. The best example for this one, Tamasic Lakshana, deactivation or forgetfulness, we can say, or Rajasic Lakshana, irritation and wavy thinking. These are two are related to your brain faculty or Medas faculty. Okay, that's why. To treat hypothyroidism, usage of medhyadravyas that with respect to Ushna Veera Pradhana medhyadravyas and Katu Kashaya Rasatmaka medhyadravyas also plays very important. This is my view, keep it in your mind. That's why you have to divide medhyadravyas into two classes. One class is Ushna Veera Pradhana medhyadravya and Shita Veera Pradhana medhyadravya. So Ushnavira Pradhana Medhyadara, the best example you can take Vacha, Tagara and Ashwagandha. And the Shita Pradhana Medhyadravas you take Shanga Pushpa and Brahman. With respect to Nasya, we in hypothyroidism you can go for Tikshna Nasya, that is a type either a type of Rechan Nasya or Shodhan Nasya. In case of hyperthyroidism, Brahman Nasya you cannot. So this critical view, to justify this critical view, I am having some examples. Those examples to justification Shanka Pushpi as Sita Vera and Ashwagandha Ushna Vera in the management of hyperthyroidism and hypothyroidism. You just screen Shanka Pushpi in your Google search. So Shanka Pushpi, it is Conolus pluricalis. It is best demonstrated as a thyroid suppressing effect when administered to mice with hyperthyroidism. So, Shankapushpi, nowadays we are using a drug of choice for hyperthyroidism where it is Shita Viratnaka, where in the previous slide I justified how medhyadravas are helpful in the management of hyperthyroidism. And on the same line, if you screen Ashwagandha, the PubMed explanation, PubMed research article, it is clearly mentioned efficacy, safety of Ashwagandha root extract in subclinical hypothyroidism. This Ashwagandha is Ushnavira. So, this is the critical view. Urdhva Jatrugata Vikara, Urdhva Jatrugata Avayava, application of Nasya, application of Medhyadravya with special reference to Ushnavira and Shitavira, and its justification with taking example of Shanka Pushpa and Ashwagandha, it is well established. That's why the suggestion to, not the suggestion, the request to Shalakya department people to concentrate on Nasya followed by Medhyadravya Prayoga in the management of hypothyroidism as well as hyperthyroidism. This is my view. Okay. Now, this is what is the name for thyroid gland. It is a reference from Sushruta Sharirasthana 5/26 with a commentary of Dallana. Dallana said, Kaklakam. Kaklakam is the exact word for thyroid gland. That's why one of famous pharmacy, Doodh Papeshwar, they are they are come up with one preparation for treating thyroid disorder. That preparation is Kakla Rakshaka Yoga. You just go through Dud Papeshwar preparation. Kakla Rakshaka Yoga. That Kakla Rakshak means Kaklakam is nothing but thyroid gland. This is exact terminology for thyroid gland. Now, for an Ayurvedic physician or for an Ayurvedic scholar, knowing basal metabolic rate, this is the most crucial for information for treating thyroid disorder or understanding thyroid disorder. If you are having low BMR, then such condition we call it as a hypothyroidism, where the biochemical investigation with respect to thyroid stimulating hormone, that is TSH value, is high. If you are having high BMR, the condition is, we call it as hyperthyroidism, and TSH value is low. So your TSH value states the BMR.
काय चार्जिंग लावती का नाही हा सकाळपासून थोडं पण नाही लावली
Sorry.
आता काय उठणार आहेस तू
Please unmute. I mean, mute yourself. Please mute yourself over this.
Kindly, all participants, please mute yours.
Okay. So it is a request to the scholars, don't get confused. Okay. Low BMR exactly opposite to high TSH value. High BMR exactly opposite to low TSH value. So low BMR not means that low TSH value. Keep it in your mind. This is very crucial information. You have to keep it in your mind. High TSH value means low BMR. Low TSH value means high BMR. Because the word hypo, low, always the scholars think of TSH value is also low. It is not like that. Low, hypo, but TSH value is high. High, hyper, but TSH value is low. This is the information you have to keep it in mind, and how to identify that your BMR status, BMR basal metabolic rate is low or high. It is depicted with respect to thyroid stimulating hormone value. That's right. How to view critically the basal metabolic rate with special reference to Ayurveda? For that, we have to concentrate on two aspects. One is Srotodushti, and the other one is Agni. If there is a Sangha Srotodushti of various Srotas, always results in Ayoga. That Ayoga you can take it as a hypo or low BMR. And in the with continuation, if we take Agni, Agni is always Mandagni or Vishmagni. Why Vishmagni? Vata is Yoga Vayu. Okay. So Mandagni always depicts low BMR or hypofunction. When it comes to Ati Pravarti Srotodushti of various Srotas results in Ati Yoga, hyper or high BMR. When it comes to Agni with special reference to Tikshna Agni, where it depicts something about high BMR hyperfunction. This is the critical view on basal metabolic rate with respect to Ayurvedic understanding, where you have to consider the two phenomena. One phenomena is Srotodushti and the phenomena is Agni, which depicts hypo and hyper with special reference to Sangha and Madnagni always says something about hypo. Ati Pravarti and Tikshna Agni always say something about hyper. This view should be kept in your mind to understand basal metabolic rate. That's why dual states of pathogenesis whenever you are treating thyroid disorders. What are those dual states of pathogenesis? One is hyper and one is hypo. So to understand hyper and hypo, we have to concentrate Manda guna of kapha dosha and Shita guna of vata and kapha dosha. Okay, you end up into hypofunction. So the dosha involvement in almost all hypofunction, the dosha involvement is always kapha and vata. And how they affect or how they exist always in a delayed manner or chronic manner. We call it as a chirakari. But in case of hyper, Ushna and Tikshna guna of pitta dosha and Ruksha guna of vata dosha exhibits always hyperfunction. So always in case of hyperactivity, the dosha involvement is always pitta as well as vata, and it is always ashukara. You experience immediate and acute effect if these two doshas are involved. Uh, in these dual state of pathogenesis, vata dosha, which is yoga vahi, it is associated with both the condition. Keep it in mind. This dual state of pathogenesis is very important to understand hyperthyroidism as well as hypothyroidism. So, this is the biochemical diagnosis for an Ayurvedic physician or scholar, where how to diagnose hypothyroidism, where T3 is low, T4 is low, TSH is raised. And keep it in your mind, total cholesterol also raised. Okay, I will discuss later about total cholesterol. And the next one is subclinical hypothyroidism, where T3 normal, T4 normal, and TSH is only raised. As per my clinical experience, almost 90% patients having the biochemical status is T3 normal, T4 normal, TSH is raised. This is very important observation what we made in our clinical practice. And hyperthyroidism, T3 is raised, T4 is raised or normal, TSH is low, total cholesterol is in maximum cases it is low or normal. And one more thyroid condition that is very important in day-to-day clinical practice, that is autoimmune thyroiditis, where you have to screen the patient's uh, NTTP or AMA blood test, where it is always high. Such raised NTTP or AMA value depicts autoimmune thyroiditis. This is the common basic understanding to diagnose hyper or hypothyroidism based on biochemical values. These are the few challenges in my clinical practice, where I mentioned them as a negative or pseudothyroidism cases, where patient having maximum symptoms of thyroidism appreciated in. But if you go for a biochemical investigations are absolutely normal. Okay, at that time, don't delay the treatment. You start your line of treatment considering the patient is having a pseudothyroidism. The one more important point here, you have to concentrate on cholesterol value also. Nowadays, it is very important to, if the patient's biochemical investigation with respect to thyroid profile is absolutely normal, but the patient's his or her cholesterol level is high and patient experiencing maximum symptoms, then that patient should be treated on the lines of thyroidism. Keep it in mind. This is very important. At that time, don't say that patient go on saying that sir, हम मैंने मेरा thyroid normal है, but ये सब symptoms. So such patient don't take it as lightly. You have to treat on either negative or pseudothyroidism. And the second clinical practice challenge is maximum cases of hypothyroidism, as we observed. Maximum hypothyroid patients are obese and hyperthyroid patients are lean. But you go through the biochemical investigation, patients are obese, but their TSH is very low. Means TSH is very low means they are depicting hyperthyroidism, but patients Akriti Pariksha is obese. And in the same reverse manner, patients are lean, but their TSH is raised. At that time, you have to treat the patients very cautiously. Okay, because obese low TSH usually it is a rare phenomenon. Lean raise TSH raise rare phenomenon. That's why this such type of cases you have to treat cautiously. And the third one nowadays, it is the most common. The most common is thyroxine induced drug induced hyperthyroidism, where patients go on taking thyroxine doses without consulting the doctor for the period of 6 months, 8 months, or 1 year, 2 year. After that, suddenly they start suffering with tremors, palpitation, all the things. At that time, you have to, if you screen the biochemical investigation, the patient ends up with hyperthyroidism status. That's why thyroxine dosage every 6 or 8 weeks. It is said 6 or 8 weeks or 2.5 months. Every 2.5 months, you have to recheck and you have to adjust the dosage. Keep it in the mind why you have to adjust the dosage, because keep it in the mind thyroxine dosage is not in milligram, it is in microgram. Keep it in the mind. That's why it is potential in that manner. That's why every 2.5 months it is said in classics that psychoneuroendocrine axis takes its resetting for in every 2 to 2.5 months. It is mentioned. That's why. And thyroxine dosage, it is in microgram, not in milligram. So this is the commonest uh, cases what we are nowadays facing with respect to thyroid disorders. This is well-known fact. If anyone ask about thyroid or thyroid disorder, the first prescription starts with the Kanchana Gugulu. Okay, it is something about doctrine of signature, the modification of Lokasamya Purushavada, where the leaf shape of leaf, Kanchana leaf, looks like that of thyroid gland. That's why we are using uh, Kanchanara in the management of thyroid gland. This is doctrine of signature, but in my clinical practice, least used drug is Kanchanara. This is my view. Don't take it seriously. Now, come to the hyperthyroidism. I will start with hyperthyroidism because, as physiology says, stimulation always causes depression. First, we will start with the stimulation. These are some symptoms of hyperthyroidism. I don't want to give a detailed explanation where, with respect to brain, you are having this one irritation, you are having fatigue, muscle weakness, problems with sleeping, muscle twitching, excessive sweating, rapid heartbeat, palpitation. Okay, these are the hand tremors we are concentrating. Uh, Unexplained weight loss, irregular. These are the some symptoms of hyperthyroidism. The common symptoms is unable to gain weight, palpitation, tremors, and sweating. These are the commonest symptoms with special reference to hyperthyroidism. Now, if you compare contemporary with the Ayurveda, okay, with respect to hyperthyroidism, you compare excessive hunger with Tikshnagni, frequent bowel movements you compare with Grahani, nervousness you compare with Glani, intolerance towards heat, Shitagrahi, difficult to concentrate, Chanchalata, scanty or irregular menstruation, Yarthodushti, fatigue, Shrama, weight loss, Krashata, sleeplessness, Anidra or Nidranasa, excessive sweating, Atisveda, tremors in extremities, Kampa. So, if we compare the contemporary symptoms with Ayurveda, then it holds true that uh, we are having unique understanding of hypothyroidism with respect to uh, dosic understanding. Okay, this is the biochemical diagnosis. What is dosic understanding? The dosic understanding is hyperthyroidism. You diagnose the condition either as Vata Pittaja or Pitta Vataja Kapha Kshaya condition. This is a dosic diagnosis of hyperthyroidism. Now, screen one by one. If you screen an Anatmaja Vikara of Vata, विड्भेद हृद्रव वेपतु अस्वप्न अनवस्थित चित्तत्व, these are common in hyperthyroidism symptoms. And with respect to pittaja nanatmaja vikara, we are having ushmadhikyata and atisveda. So you just screen the nanatmaja vikaras of vataja and nanatmaja vikaras of pittaja. So the permutation and combination of nanatmaja vikara definitely says something about hyperthyroidism in Ayurveda. Then, same if you screen Prakupita Vavstha of Vata, where it is said that Kampa, which is common in as a tremor, you compare it with a tremor, common in hyperthyroidism, and Pitta Prakupita, Ushna or Sweda. These are the commonest complaints in hyperthyroidism. The same if you screen Vata Ruddhi, then Pitta Ruddhi Lakshana. So Vata Ruddhi Lakshana, it is said that Karsha, which is most common, Kampa and Nidra Bhav. Okay. Then in case of Pitta Ruddhi Lakshana, we are having Kshutta So that is nothing but Tikshnagni or Bhasmakara Yoga, you say. then alpanidrata. So if you diagnose hyperthyroidism at the level of dosic understanding, the dosic understanding is the hyperthyroidism is nothing but vata pittaja or pitta vataja kapakaya condition. Okay, this is a critical review with respect to dosic understanding. That's why you are having two phenomena, either vata tama, tama. If you understand the tamatara phenomena, vata tama, pitta tara, kapakshaya, or pitta tama, vata tara, or kapakshaya. Uh, States are usually exhibits in hyperthyroidism. So, what is the understanding with special reference to dhatu level of hyperthyroidism? So, dhatu level understanding, we are having rasa, meda, and mosa. So, if you screen rasa lakshanas, we are having shosha, shrama, shabda yashuta. Okay, you just compare these symptoms with the symptoms of hyperthyroidism. And with respect to meda, it is krasha. And medamala is sweda. And rasa upadatu is artava. That's why artava dushti lakshanas are commonly seen. Then rasava sruto mula is hridaya. That's why we are having hridrava or palpitation symptoms are common in hyperthyroidism. That's why this is the dosing. See, one more mausa. So mausa ruddhi pradosha ganda gandamala granthi. See, hyperthyroidism patients are more prone for nodules or multinodular goiter or nodule formation in the thyroid gland. That's why also involvement is also there if you are not properly managed or understand rasa and medo dhatu dushti lakshana in hyperthyroidism. This is the dhatu level understanding of hyperthyroidism. Next is you just go through the gunatmaka understanding. Gunatmaka understanding, as I said, vata pittaja always depicts hyperactivity or hyperfunction. So in hyperthyroidism, the lagu guna of vata dosha, that is krashata, and chalaguna of vata dosha, where it is said kampa, vepatu, vidbheda, that is tremors, palpitations, irritable bowel syndrome, lack of concentration. These are all common in hyperthyroidism. That's why laguguna of vata dosha and chalaguna of vata dosha, the most responsible gunas in the manifestation of hyperthyroidism. In the same manner, if you screen pitta dosha, the Ushna guna of Pitta, which is produces sweda, excess sweating, and Tikshna guna, Ushma Dikshata, the intolerance to heat. These are the two gunas are responsible for uh, the two gunas of Pitta dosha are responsible for the manifestation of different systems in hyperthyroidism. That's why Gunatmaka Adhyayana of hyperthyroidism states that the Lagu and Chalaguna of Vata dosha and Ushna and Tikshna guna of Pitta doshas are held responsible for the manifestation of different symptoms of hyperthyroidism. Coming to the Agni, understanding of Agni, where Agni, status of Agni in hyperthyroidism is Tikshna Agni, that is with respect to Pitta dosha, Vishma Agni with respect to Vata dosha. So there may be a chance of Vishma Agni followed by Tikshna Agni, Tikshna Agni followed by Vishma Agni. That's why. With respect to Tikshna Charaka Chikitsa, 15th he has said that Bhasmaka Roga. So, in maximum context or maximum physicians consider hyperthyroidism correlate with Bhasmaka Roga under the concept of Agni. So, considering the Dushti, Agni Dushti is Tikshna. So, in such cases, understanding of Krasa Chikitsa in Ashtanidita for better management. This is the understanding or this is the critical view on Agni with special reference to hyperthyroidism. So we are having so many diagnoses, understanding for hyperthyroidism as per senior professor late Dr. S.N. Oja sir, where he treated so many thyroid cases on the basis of Samanavrata Udana. Okay, and Pittavrata Udana, if you go through this explanation, Pittavrata Udana, which mimics the symptoms of hyperthyroidism, and Pitta Vruddhi Lakshanas, Again, a simple understanding where Agni in the body is Pitta, Pitta Ruddhi, Kopa Lakshana as if you screen. Absolute importance to Pitta dosha in the management of hyperthyroidism. Okay, control mainly Ushna and Tikshna guna of Vata. That's why we are giving Snidha Virechana in the management of hyperthyroidism. So this is a simple understanding of hyperthyroidism that it is Pitta Ruddhi, where you have to control Ushna and Tikshna guna of Pitta. For controlling Ushna and Tikshna guna of Pitta, you give Snigdha Virechana. This is the simple understanding. It is left to individual physician. Then Galaganda, we never consider diagnose the condition hypo or hyperthyroidism as Galganda. We consider multinodular goiter toxic or non-toxic multinodular goiter. We consider as a Galganda, which is best explained in considered as a Ekadeshe Shota. It is again one of the Kafaja Nanapajakara. That's why this is the complication of hyperthyroidism. As per my view, if you are not treating hyperthyroidism, most of the hyperthyroidism patients are more prone for nodular growths in the thyroid gland. So again, two different approaches, therapeutic approaches, and two different doshas as per its structure and function. Okay, this starts from physiology. Here in physiology, basic physiology says that thyroid is located in the sixth level of Majja Dhatu. Majja is controlled by Kapha dosha, and function of Pitta, thyroid function is controlled by Pitta dosha. Pitta is responsible for all of the metabolic actions carried out by the thyroid gland. So you can approach either structural change. If there is a structural changes, you approach with Kapha dosha. If there is a functional changes, you approach with Pitta dosha. So these are the some treating strategies that you can adopt. The treating strategy you can use the principles of Apyagni, Grahani, Karsha, Vishmagni, Kshaya, and Rajakshma. It all depends on yukti of a physician. I am having few critical views on few prescription, especially with respect to hyperthyroidism. As per my view, the Kshirapaka preparations and Sneha practice. That Sneha is nothing but Shamana Sneha is ultimate. Is best indicated or best prescription to manage hyperthyroidism cases. For example, in my clinical practice, I usually go for a capsule Kshirabala 101 with empty stomach with hot water. See, one capsule is equal to 15 drops, 15 drops equal to 1 ml. So you can go up to 5 capsules. If you screen this, critically analyze this Hirabala 101 with respect to symptoms of hyperthyroidism. So hyperthyroidism is Vata Pradhana. Okay. So Taila is the best for Vata. Kshira is Jivaniyanam. Maximum hyperthyroidism patients are non-nutritional or underweight. Okay. Then Bala is the best belly. Maximum they are having need energy. Best belly Bala Vatahara. Pittahara Kapha Vardaka, which is most important action we need in the management of hyperthyroidism. That action is exhibited by Kshirabala 101, that is Vata, Pitta, and Kapha Vardaka. And also it is best for Rasakshaya as well as Krishata. If you analyze critically Kshirabala 101, that's why I said it is Kshirabala 101, it is an oil preparation. We are giving it in an empty stomach with hot water, easy to absorb, in the format of Shamana Sneha, low dose. And in the same manner, if you go for Kshirapaka, so Kshirapaka, Ashwagandha, Arjuna, Dashmula, Shatavari, Eshtimadu Kshirapaka, these are best prescribed in the management of hyperthyroidism. That's why usually in my clinical practice, we are only concentrating on Shamana and Kshirapaka preparation in the management of hyperthyroidism. Again, regularly we are using Brihatvat Sintamandras, which is best for palpitation and tremors in hyperthyroidism, which controls Telaguna of Vata. And with respect to sweating, we are concentrating much more on Dhatura preparation in low dose, not in a higher dose. For example, Sutta Shikras and Kankasava, excess sweating. Because Dhatura, the main ingredient is atropine. The low dose atropine blocks the acetylcholine activity. What is acetylcholine activity? Acetylcholine activity, hyperactivity, it increases the bodily secretions. That's why if you block acetylcholine activity, there may be a chance of maximum outcome is a decrease of sweating, but don't go for an excess dosage because atropine also causes uh, atropine usually given in bradycardia. Okay, but in hyperthyroidism cases we are having trachycardia symptoms. That's why keep it in your mind. uh, for sweating, if you are going for any datura, keep it for a minimal period. So these are some various common prescription what we are concentrating. If you are going for panchakarma, then vata pradhana you go for basti, pitta pradhana, snigdha virechana, krashata, shirabala not one, atisveda, dhatura preparation, pitta tikshna guna, if you go for chandrakala and mukta pishti, pitta ushna guna you go for kamadudarasa, vata lagu guna, vata increased go for brahmana, and vata chalaguna as I said Bharatva Chintamanirsa or Perpetikalpana in case of hyperthyroidism patient having IBS complaint. If there is a Asahishnata, you go for Ashwagandha and Shatavari. These are some common prescription we are following. This is something about hyperthyroidism. Now we have to concentrate on depression phenomena, that is hypofunction, that is hypothyroidism. These are some causes of hypothyroidism. I don't want to go in detail because so many causes. It is commonly said that iodine deficiency in diet. This is the one important. What we have to concentrate or we have to discuss. So we are having three causes for hypothyroidism. Primary cause failure of thyroid gland. Secondary cause it is with pituitary disease. Third cause is tertiary hypothalamic disease causing reduced TRH. These are some signs and symptoms of hypothyroidism where forgetfulness, weight gain, hair loss, then constipation, irregular menses, bradycardia. These are all coldness of extremities. These are all commonest symptoms of hypothyroidism. Okay, how to diagnose? I already discussed that. Subclinical hypothyroidism, T3 should be low, T4 should be low, TSH is raised, total cholesterol is raised. Subclinical hypothyroidism, T3 normal, T4 normal, TSH raised, total cholesterol is raised. As I said, pseudo hypothyroidism or negative hypothyroidism, where T3 normal, T4 normal, TSH normal, but total cholesterol is raised with all the symptoms appreciated in the patient. Now, come to the critical views on hypothyroidism, like that of hyperthyroidism. Exactly opposite to hyperthyroidism is hypothyroidism. It is kapha vata or vata kapha samsarga javadi, but hyperthyroidism is vata pitta or pitta vata samsarga javadi. So, kapha vata or vata kapha samsarga javadi, where manda, shita, and guruguna of kapha are most responsible for the manifestation of hypothyroidism. In these three gunas, manda guna of kapha having the key role in vikalpa samprapti. That's why you have to concentrate. And the next is the shita guna of vata dosha. The shita guna of vata dosha, which is having yoga vai property of having a strong contribution in the manifestation of hypothyroidism. That's why. In case of hypothyroidism, what is the status of Agni? The status of Agni is Mandagni or Ishmagni. But not in case of hyperthyroidism, there is Tikshnaagni or Vishmagni. So, Mandagni depicts lower BMR followed by raised TSH. And Dosha, as I said, Dosha is Vata Kapaja or Kapha Vataja. Hypothyroidism is always Vata Kapaja or Kapha Vata condition. And if you take Manodosha, always Manodosha is tamasic lakshana we are having inactive status, but in case of hyperthyroidism, it is Rajasika, hyperactive status. That's why forgetfulness is one of the symptom with respect to tamasic lakshana. Then Srotodushti, the Srotodushti in hypothyroidism is Sangha in maximum cases. But in hyperthyroidism, we consider it as ati pravritti. For example of Sangha Srotodushti, patient is having constipation, patient is having scanty menses, patient is having bradycardia. So, assessing hypothyroidism on the doshic line, the doshic line is if you screen Kaparuddhi Lakshana, that is Agni Sadhana, आलस्य गौरवं शैत्यता स्लतांगत्वम अतिनिद्रा. So excess sleep, laziness, heaviness of the body, cold intolerance, these are all common symptoms present in hypothyroidism depicts with respect to kapha viruddha lakshana. And I use the word in case of hypothyroidism as vata dushti, because in vata, why I am not used vata vruddhi or vata like that. I use the peculiarly use the word vata dushti because we are patient is having in some patient we are having vata vruddhi lakshana as well as vata kshaya lakshana also. For example, vata vruddhi lakshana shakrat grahan, that is constipation, we compare ushna kamitva, balabhramsha, these are all some vata vruddhi lakshanas we appreciate in the patient. In vata kshaya lakshana angasada and alpachesta, patients are having a deactive status. So that's why I use the word vata dushti. That's why hypothyroidism is a status of kapha vruddhi and vata dushti lakshana, vata dushti janya. Okay, not vata vruddhi or vata kshaya. So Mandaguna of kapha. Then these are some critical views where Mandaguna of kapha, you just the patient is having bradycardia, you think of vata kshaya lakshana, where uh, Mandaguna of kapha plays a very important role in the manifestation of bradycardia. You come to the Shita Guna. This Shita Guna is common in both Vata and Kapha. Tatra Ruksha Lagu Shita Kara Sukshma Chalo Nilaha Kapha Snigdha Shito Gurur Mando. So, cold intolerance in hypothyroidism is common. That cold intolerance is because of Shita Guna of Vata dosha and Shita Guna of Kapha dosha. That's why application of Shita Prashamana Dashemani of Charaka Sutra. This is very important. We are clinically we are not concentrating Shita Prashamana Dashemani in day-to-day practice, but application of Shita Prashamana Dashemani in the management of cold intolerance with special reference to hypothyroidism, it is a better prescription as per my view. Then coming to Guru Guna of Kapha dosha, where Gauravata, the responsibility is Guru Guna of Kapha dosha, Alasya and Medo Ruddhi, Guru Guna, Guru, Brahmane Guru. Okay, Vedo Ruddhi, weight gain, it is again a Guru Guna of Kapha dosha. That's why the Lekhni and the Shemani or Kapha Medo Haragana of Sushrut science is best prescribed in the management of Guru Guna of Kapha dosha. Okay. So, lack of energy, this is the commonest symptom in the hypothyroidism patient, that they go on saying that myalgia and weakness. So, Angamardha Prashamna Dashimani drugs are best used in place of bullet drugs in this context. Especially best practiced in case of symptoms like Sratangatvam, Angasada, or Balabhramsha, where Kaparuddhi Lakshana, Vatakshaya Lakshana, and Vataruddhi Lakshana, you can use Angamardha Prashamna Dashimani drugs for the management of lack of energy symptoms. So, this is my critical view on Nidana etiological factors. It is mentioned that we are having iodine deficiency, iodine. But iodine is this iodine deficiency, as per my is, it is only appreciated in classical thyroidism. What is classical thyroidism? Where the T3 level should be low, T4 should be low, TSS should be high. Okay, or in case of hyperthyroidism, the same reversed condition. But when you screen the patients, in our OPD, 90% patients are females. That's why I call hypothyroidism as housewife disease, because if you screen the lifestyle of most of the housewives, they are having improper food timing. This improper food timing lowers the BMR, and they are having non-nutritional food. They are always housewives are more prone for stale foods. It lowers the BMR. Then they are having unwanted stressful activities. This unwanted stressful activity increases the cortisol hormone, that is stress hormone. In turn, it lowers the BMR. Okay, so Mithya Ahara Vihara. Mithya Ahara Vihara is one of the major cause rather than iodine deficiency in case of hypothyroidism. And in my OPD, 90% cases are subclinical hypothyroidism. Hardly we appreciate one or two cases of classical hypothyroidism. That's why I am saying that if you screen any hypothyroid patient, female hypothyroid patient, with respect to their nidana, their lifestyle, always they follow these three phenomena. Those three phenomena are improper food timing, stale food, unwanted stressful activity, and they end up with low BMR. Low BMR end up with a biochemical outcome. That biochemical outcome is raised TSH level, but their T3 and T4 value is absolutely normal. In that T3 is most active hormone, still it is normal. So it depicts that there is only basal metabolic is disturbed. That disturbed basal metabolic rate is disturbed because not because of iodine, it is because of improper food and lifestyle. Keep it in our mind, because the supplement is only hormone replacement therapy is only followed in modern practice. If hormone less, give synthetic hormone, no other treatment facilities, because whole hypothyroidism treated with only one drug, that is thyroxine. That thyroxine is nothing but hormone. That hormone is nothing but considered as replacement therapy. Other than thyroxine, they don't have any other medication. So this is my view. It is observed facts, as we did 44 grams from 2015 to 2019 in association with Thyrocare Limited, Mumbai. When we screen blood profile observation, more than 200 250 patients, maximum patients of hypothyroidism, they are having low serum iron. Okay, so it gives us an inference, that is a view that our Acharya Chakralta mentioned low rasana prayoga in the management of obesity and hypothyroidism. Obesity. So we adopted this phenomena in our clinical practice, where we are in a few cases we are treating hypothyroidism on the lines of Kapaja Pandu Chikitsa, where patient obese but their HB percent is very low. Such patient we are treating with low rasayana therapy, that is Tappadiloha, Punarnava Mandora, Tayushanadiloha, Navayasanova, and Ayaskati Prayoga. Where so Kapaja Pandu Chikitsa, why we adopted? We adopted because of our observation, where maximum hypothyroidism patients having a low serum iron, and we are having a reference of Chakrata, low rasayana prayoga. So these all things helps us to, or made us to usage of different lower preparation in the management of hypothyroidism, not iodine. Keep it in our mind. That's all. You just follow the treatment strategy. Other than this, few practice and follow the Staula Chikitsa. Few people, as I said, Kapaja Pandu Chikitsa. Few people followed Shodha Chikitsa. One more follow up is Medasa Avrata Vata Chikitsa. You just go through the Medasa Avrata Vata Chikitsa, where it is said that Prameha Vata Medognim Amati Prayoje. So the permutation and combination of Prameya Chikitsa, Vata Chikitsa, Medogna Chikitsa, and Amata Chikitsa is best prescribed in the management of Medasa Avrata Vata Chikitsa. So in few conditions, I consider hypothyroidism with Medasa Avrata Vata. So, coming to the next critical view with respect to hypothyroidism, where it is said that you can compare it with the Rasa Pradosha Vikara. You screen the symptoms of Rasa Pradosha Vikara. Almost all Vikaras or all symptoms are correlated with symptoms of signs and symptoms of hypothyroidism, except Krashangata. This one word Krashangata, except Krashangata, all other Rasa Pradosha Rogas are mimics or depicts the signs and symptoms of hypothyroidism. Now, come to, in few cases, we are applying Amavata Chikitsa Sutra with special reference to hypothyroidism. That is, especially in case of autoimmune thyroiditis, where raised NT-TP level or AML level are high, where we are concentrating Amavata, as it is a best relative illustration of autoimmunity. So, autoimmune thyroiditis, we are concentrating Amavata Chikitsa Sutra, because Ama, again, it is Ama means Kapha Vata Chikitsa Sutra. Along with this, we are concentrating some immunomodulator drugs in the management of autoimmune thyroiditis. As per me, my view, few patients of autoimmune thyroiditis, they are unnecessarily taking thyroxine medication, thyroxine hormone, but it never helps in their NT-TPO level. This is my observation with respect to autoimmune thyroiditis. So keep it in mind whenever you are treating any endocrinological disorder. Endocrinological disorder always it is multi-srotas involvement. So when there is a multi-srotas involvement, always it depicts Bhaudoshavastha. When there is a Bhaudoshavastha, the line of treatment must be Shodhana. Uh, the best example for Bhaudoshavastha is Kushta, where it is said that Pakshat Ayane Virechanam, Mase Virechanam, Ayane Raktamoksham. Such Shodhana line of treatment you have to adopt whenever you are treating multi-srotas involvement diseases, commonly endocrinological disease. You can follow Shodhana line of either classical or Kalata, Sharade Virechanam, Vasante Vamana, or Nitya Shodhana. You go for some Katuki, Arogyavardhini Vati, or you go for some Triurut on the daily basis, Nitya Virechana line of treatment, you can adopt to control Bhaudoshavastha. This is very important phenomena whenever you are treating endocrinological disorders. These are some views beyond the boundaries. Okay, uh, those who are the strong follower of Charaka, uh, you have to follow Jwara Chikitsa Sutra and Grahani Chikitsa principle hold true in the management of thyroid disorder. Keep it in mind. I said it is a beyond the boundaries. So I will give you some example where Sita the Jwara, which mimics hypothyroidism, which is Vata Kapha dominant, and Daha the Jwara, which mimics hyper. You just go and read Daha the Jwara, which mimics hyperthyroidism, Vata and Pitta dominant. So, Grahani Chikitsa, where Chitraka Divati, Grahani Chikitsa is applicable to Mandagni related hypothyroidism. Okay, what are the Takra Kalpanas of Grahani Chikitsa? Best for Agni Dipti and Sotodushti in hypothyroidism. And if you read Grahani in Vagbhata, Grahani Chikitsa, it is said that Atyagni leads to Dhatupaka. This phenomenon is most relevant in hyperthyroidism. That's why, beyond the boundaries, if you want to think, you think of treating thyroid disorder on the principles of Jwara Chikitsa and Grahani Chikitsa. I quoted few examples. And my view beyond boundaries, my view is I always concentrate endocrinological disorders or thyroid disorders under Dhatugata concept, most appreciated in my clinical practice with special reference to endocrinology. So, if we screen classical Ayurvedic test, especially Charaka, we are having only mainly three diseases with special reference to Dhatugata. Those three diseases are Jwara, because in Jwara it is said that Rasa Dhatugata Jwara, Rakta Dhatugata Jwara. Same with respect to Kushta, same with respect to Vata Vyadi. So, if you read these three diseases with special reference to Dhatugata concept of these three diseases, in depth understanding and adopting principles of Dhatugata, definitely have better outcome in the management of neuroendocrine disease. This is my view. So, for updated example, for my understanding, Dhatugata concept, nowadays vitiligo, Switra, as we studied or we know that Switra is Kushta, variety of Kushta, but whenever patient starts suffering from vitiligo or Switra, it is better to screen one's thyroid function. Okay, we are having so many references. I quoted one reference of antiseptic volume one, volume November 2014. Uh, that's why nowadays Switra, it is a type of coaster considering under endocrine disorder. This is this explanation why I added to justify Dhatugata, to justify Dhatugata concept of Jwara, Kushta, and Vata, how they are leading to neuroendocrinological disorders. So, I am having my own contribution to the field of endocrinology, as I am a initiator and just a budding uh, person. So we completed two theses on endocrinological part. One is on clinical evaluation of Vamana karma in the management of autoimmune thyroidism, uh, where we consider the case of raised NTTPO level, and in that we went for Varnadikrita Snehapana followed by Vamana karma, uh, under did by our one of the scholar, Dr. Sham, and we also completed evaluation of Mundi Panchanga Churna in the management of subclinical hypothyroidism. Okay, it gives wonderful results in subclinical hypothyroidism cases, and we are having ongoing two theses, that is evaluation of Ashwagandha Churna in hypothyroidism, especially in females. Uh, then we are having one more, recently we started evaluation of Shikru Patra Churna tablet in subclinical hypothyroidism. These are contribution where we are concentrating on different drugs and single drugs in the management of uh, subclinical thyroidism cases, as well as hyper. Yet we are not started hyperthyroidism. Uh, just we are now concentrating only hypothyroidism. Later we are going to concentrate on hypothyroidism. These are our four contributions. Just to go through the details available in Kale University. So with the last word, this is the last word that I am not full and final. My words are not full and final. That's why I am open for my possibilities, and I am open for choices. And I always welcome new ideas. I am always eager to learn. I am never going to close my mind from learning. This is my last word. With this last word, I am saying wholehearted thanks to organizing chairman Professor Sanjay Sharma sir, Vice Chancellor of NIJ, and organizing secretary Professor Shamsha Fayaz, HOD of Shalakyatantra, and coordinators of the event. Those are faculty of Shalakya and PhD scholars and PG scholars of Shalakya Department of NI and NIA Jaipur. Thank you, one and all. Now I over to Malasri, Dr. Malasri.
Yes, sir. Thank you, sir. Thank you, sir. Thyroid gland plays a major role in the metabolism and growth and development of the human body. And its pathologies are must to know for a clinician because its symptoms are multisystemic presentations, and the prevalence and incidence of the thyroid disorders are increasing day by day. And it's a must to know topic for all the clinicians. And thank you so much to Dr. Arun Chogle, sir, Professor and HOD, Department of Dravyaguna, for deciphering many Ayurvedic concepts. Condition for deciphering many concepts of Ayurveda, Ayurveda concept of thyroid disorders. Thank you so much, sir, on behalf of NIA family and the present participants of the webinar. Thank you so much. Now, and any questions are there? We will be discussing at the end of the webinar session. Participants, please note, at the end of the session, we'll be discussing about the questions. And now we're moving towards the next guest lecture by Dr. Sanjay Saran, sir, Associate Professor, SMS Medical College, Jaipur. I request Dr. Pratima to introduce our guest speaker. Over to you, Pratima.
Thank you, Dr. Malasri ma'am. A very good afternoon to one and all again. I am taking the privilege to be introducing the second guest speaker for today's event, Dr. Sanjay Saran sir. Dr. Sanjay Saran is currently working as an associate professor in the Department of Endocrinology, SMS Medical College, Jaipur, India. And sir is also working as Secretary, Endocrine Society of India, Rajasthan affiliate. Sir has worked as Organizing Secretary of ESICON 2022. Sir has multiple awards and honors on his bag. Sir has more than 40 publications in various national and international journals. Sir has published 3 papers in international books. Sir has done more than 100 presentations in various national and international conferences. Sir was awarded by Government of China for excellence in the field of medicine. Sir has received Jaipur Epicon 98 award. Sir's areas of interest are diabetes mellitus, nutrition, metabolism, growth and development, type 1 diabetes, disorder of puberty, thyroid disease, and reproductive endocrinology. We feel immensely blessed to have you with you here, sir. A warm welcome from the organizing committee. Over to you, Dr. Malashri, ma'am.
Thank you so much, Dr. Pratima, for introducing our second guest lecturer. Sir, Sanjay Saran sir is here with us. Sir, we will not delay with the session. It's over to you, sir. You can proceed with the presentation, sir. Over to you, sir.
Yeah, thank you. I am very thankful for the organizers and Dr. Malashri for providing such a great opportunity to interact with peoples or to just make some spread the awareness regarding the thyroid disorders. Otherwise, I am very thankful for Dr. Pratima for my kind introduction. So without delay, let me share the slides. Is it possible? If it is possible from my side, let me try. So, no. Yeah, Dr. Malashri, can you share my slide? Actually, here it's difficult. Some problem is there in my iPad, I think. So.
Yes, sir. I'll arrange for the same. Give me 2, sir, please.
Yeah.
Sir, you can present from your source, sir. You can present from the slideshare. You can do, sir.
Yeah, actually, some restrictions are there, I think, in my iPad with Google Meet now. So it's not possible to share the slides now here.
Okay, sir. Okay, sir. Okay.
Yeah.
Okay, sir. Sir, I have got your 2 PPTs. Which one I have to share, sir?
Any of one you can share right now. Then next one you after the finishing of the first one. No?
Okay, sir. Okay.
Okay, let them share the slides. Meanwhile, we can start with our just sharing the knowledge regarding the hypothyroid or thyroid disorders. So we know thyroid disease is the most common endocrine disorders if you're considering all over the world. So it's very common, and particularly in India, it is very common. Why in India? Because of the awareness is a big factor for the development of hypothyroidism also, particularly iodine deficiency disorders. So in the worldwide, if you are considering iodine deficiency disorders, these are the most common cause of hypothyroidism in worldwide. Or if in India we are going, still the iodine deficiency disorder are the most common cause of hypothyroidism in India also. Yeah, if you're considering the developed countries like Europe and US like that now, where there the autoimmune thyroid disease is the most common cause of hypothyroidism. So these are the causes as we are considering. If you are going through the epidemiology, so thyroid disorders, particularly hypothyroidism, it's very common and it is around 3 to 4% in various parts of world. But if you are considering in India, recently we have published an article considering 11 cities of India. If we have seen, so it is around 11% as a whole part of India. So I think they have shared my slides. So still in India, it is around 11 to 12%. It is somewhere it is around 20%, and somewhere it is around 5 to 6%. If you go through the this Tamil Nadu or Kerala, it is much more than if you go through the northern part of India, particularly in the central part of India like Delhi or adjacent part. If you are going through the other upper part, like in the sub-Himalayan region, the prevalence is much more than other parts of India. So the prevalence is more in some sub-Himalayan region or in Tamil Nadu or in Kerala, like cities like this. So next slide. So
Sir, sorry for inconvenience. Sir, your slides are visible on screen, sir.
yeah, okay, my slides are visible. So again, next I have to say the next na.
Yes, sir.
Command is not in my hand. Na? So
Yes, sir.
now next slide, please. Na?
Yes, sir.
So if we divide the hypothyroid means if the thyroid is dysfunctions, particularly thyroid functions are lesser than the requirement. So hypothyroidism can be divided into hypothyroidism, that is clinical hypothyroidism, or subclinical hypothyroidism. Then we consider the both of the disorder during the pregnancy also. Next slide, please. So as I've already explained regarding the prevalence of hypothyroidism in India, so it is around 11 to 12%. So every 1 in 10 people in India is hypothyroidism, is suffering from hypothyroidism. So if calculating the total number, it is around 42 million people in India have the thyroid disorders. Prevalence of subclinical hypothyroidism much more than clinical hypothyroidism. Next slide, please. So we have considered the major cities of India where we have seen the prevalence of hypothyroidism. So if we are considering these major cities, so highest prevalence of hypothyroidism was seen in Kolkata. Next slide, please. And so in Kolkata, it was the very highest, the prevalence of hypothyroidism was there. If we consider the other cities, so where it is very lesser in the part of some Delhi or Ahmedabad, in the flatter area, it is lesser as compared to some hilly area. Sub-Himalayan region is much more. Next slide, please. So if you go through the thyroid pathophysiology, so here the hypothalamus. So hypothalamus secrete the TRS, thyroid, this TSS releasing hormone. So where it works on the anterior pituitary gland. So where the pituitary secretes the TSH, thyroid stimulating hormone. From thyroid stimulating hormone, it acts on the thyroid gland where it causes secretion and formation of T4 and T3 hormones. So T4 and T3 hormones act on the tissue, act on the receptor on the peripheral tissues. Particularly T4 can be converted into T3 and reverse T3. So reverse T3, it doesn't have this metabolic activity or on the receptor activity. But T3 is the most active hormone. Even T4 quantity, if seen in the blood, so quantity of T4 is much more than T3. It is more than 100 times more than T3. But at the tissue level we go, because the various tissues, they are having their own enzyme, D1 enzyme, which converts the T4 hormone to T3 at the tissue level. So if we go through the tissue level, so T3 concentration is more than T4 at the tissue level. Next slide, please. So now we are going to the types of hypothyroidism. It can be primary hypothyroidism from the destruction of its thyroid gland, or it can be secondary or central hypothyroidism. It may be because of deficient production of TSH hormone from the pituitary gland, because of some cellular lesion or some tumor of destruction or some radiation, whatever it is. Then come to the tertiary hypothyroidism. So tertiary hypothyroidism is because of the some dysfunction of hypothalamus, where the TRH releasing is very less. So at that time it can be tertiary hypothyroidism. Next slide, please. So most commonly we see the primary hypothyroidism, then secondary. Very infrequently we have seen we see the secondary hypothyroidism, but tertiary is very less. Next slide, please. So if we discuss the primary hypothyroidism, so causes of primary hypothyroidism, it can be congenital. So congenital is from the birth. So it can be because of agenesis of thyroid gland. Thyroid gland is not formed. It can be because of defective thyroid hormone formation. It can be because of some ectopic thyroid gland, when the thyroid gland is not at the right place. Or it can be thyroid destruction as a chronic autoimmune disease, thyroid disease, or maybe because of radiation, destruction of thyroid, or maybe because of surgery of thyroid gland, or maybe some infiltrative disorder of thyroid gland like hemochromatosis, or some infective disorder like tuberculosis or like that, or maybe because of some drugs which act on the thyroid gland and they can cause this destruction, or some thyroiditis, some inflammation inside the thyroid gland like lithium iodine containing contrast media, or some interferon alpha. So mainly the main cause of primary hypothyroidism in India or worldwide, we consider it is iodine deficiency disorders. Otherwise, in developed country, it is because of Hashimoto thyroiditis. Next slide, please. So now the clinical features. These are various clinical features of hypothyroidism. So if you go through the symptom wise, so there must be patients are usually presented with tiredness or this forgetfulness or some irritability, depression, like these symptoms are there. Symptoms are very vague in hypothyroidism. Many of the patients, they are saying that we are having such kind of symptoms, but actually in usual normal population also, they can say we are having such kind of symptoms. So symptoms are very vague. Like some, if the hypothyroidism is full blown, we can say the gross hypothyroidism is there, then we get the most of these symptoms like thinning of hair, loss of body hairs, dry patchy skin, weight gain, cold intolerance, elevated cholesterol, or family, or we can get the family history of thyroid disease or diabetes in patients. If we go through the signs, then fluffy eyes can be there in case of hypothyroidism. If we go through the hyperthyroidism, there's large eyes, we can say the that grows graves orbitopathy, we are saying. So exophthalmos is there in hyperthyroidism, but in hypothyroidism, fluffy eyes are there. So swelling around the eyes is there. And large thyroid gland, that is known as goiter, we can see in hyper, any thyroid disorder we can get. Voice is also very hoarse in case of hypothyroidism, or persistent dry or sore throat may be there in some patients, difficulty in swallowing, slower heartbeat is there, infertility. Menstrual irregularity is one of the very common symptoms in hypothyroidism or hyperthyroidism, any thyroid disorder. Constipation can be there, and muscle soreness or cramps can be there. Many of the patients are presenting with muscle cramps. In those patients, we can see the thyroid disorder or some dehydration or some electrolyte disturbances, or may get some deficiency of particular vitamins. But thyroid disorders are very common cause of muscle cramps. Next slide, please. So if you go through the frequency of the symptoms, which kind of symptoms are much more common than other symptoms? Next slide, please. So we know the many of the patients are presenting with all the symptoms.
The slide is changed, sir, but I think because of network, it's delaying in showing, sir.
Okay.
Hello?
Okay. Yeah.
Okay, sir.
So still it is not changed here. Okay. So now, if you go through the symptoms, so epidemiology of symptoms, if you are going, so here so mostly we see the this goiter. Goiter is present in many of the patients, like 56% of the patient in one study in KM Hospital, Mumbai. Otherwise, cold intolerance is also there, or we see the weight gain. Patients are presenting with weight gain. Many of the patients are presenting with weight gain with hypothyroidism, but not all the patients, because the many patients are coming to our OPD. They are saying we are having some obesity, we are obese because of thyroid disorder. But if you are going through the testing investigations, it's not the hypothyroidism. So weight gain is particularly because of the eating habits and lack of exercise. Maybe in thyroid disorder weight gain can be there, but it is very less in terms of 2 to 3 kg only. In some patients, when they are grossly hypothyroid, there may be some 5-6 kg weight gain, otherwise not much more than that. Lethargy is very common in hypothyroidism. Change in voice, decrease in appetite is also there. Patients are saying my appetite is decreased, but still I'm getting obese. So this is seen in hypothyroidism. So weight gain is particularly because of the accumulation of the fluids inside the body that causes the weight gain. Once we start the treatment, obviously within few days we see the weight loss in the patients. Next slide, please. So now come to the testing. To see the hypothyroidism, to see the thyroid disorder, we go through the testing, blood testing. First testing is TSH, T3 and T4. We are going cumulatively in one patient. If the patient is already hypothyroid, then already the treatment, then we see the TSH only. So what should be the normal value of the TSH? So in India, we don't have our own data. Otherwise, we would have taken our own normal limit of thyroid on this TSH value. But in various studies, next slide, please. So in various countries or some various societies, they are having their own value of this TSH. Like Mayo Clinic, they are considering the 0.3 to 0.5 is normal value. But here, if you go to the plant change in upper limit in the Mayo Clinic, they are saying it's 4.2 is okay. If it is more than 4.2, then they increase the dose of this levothyroxine. Otherwise, American College of this clinical endocrinologists, they are saying it is around 0.3 to 3. And in considering the pregnancy, it is around 0.1 to 2.5 in first trimester, and then second trimester 0.2 to 0.2 to 3. And in third trimester, they're saying it should be in between 0.3 to 3. It's okay. But here in India, we don't have our own data, so we are considering the 4.2, the upper limit. If it is more than that, then we consider the patient is having some thyroid abnormality, maybe subclinical hypothyroidism or hypothyroidism or something else is there. Next slide, please. So what should be the treatment of hypothyroidism? Once we diagnose with the symptoms, then we go through the testing, and testing is showing high TSH level in case of primary hypothyroidism and low T4 level. So at that time, the treatment of choice is levothyroxine therapy. So levothyroxine we give in the dose of 1.6 to 1.8 microgram per kg body weight per day. It should be taken empty stomach, or it can be taken at the bedtime 4 hours after taking dinner. So it should be taken at least 4 hours before taking some iron or calcium containing medications. But still, we know the interference of other medicines is there with the levothyroxine therapy. If we are getting some proton pump inhibitors like antacids or some this PPI type of drugs, they can interfere with the absorption of levothyroxine treatment. Calcium or iron, they also interfere in the absorption of levothyroxine treatment. Bisalt, sequestrants, there are a lot of n number of drugs which causes interference in the absorption of levothyroxine. So as far as dietary, there is no diet restriction in case of thyroid disorders. So sometimes you have seen the patients are saying that I'm not getting that salt, or I should take some other kind of fruits. I should not take like cauliflower or like that things. And so it is not there. So we don't have any kind of dietary restriction in case of thyroid disorders. Next slide, please. So this was the outline of this hypothyroidism, what we have considered. Now we are coming to the subclinical hypothyroidism. So next slide, please. Subclinical hypothyroidism is a condition where TSS value is higher than the normal, but still T4 and T3 levels are normal. So here's a subclinical hypothyroidism. So if the TSS value is more than 4.2, but T3 and T4 are normal, then it is subclinical hypothyroidism. Next slide, please. So if you go through the sign and symptoms of this subclinical hypothyroidism, obviously they are same as clinical hypothyroidism, which we have already discussed, but a lesser intensity. Intensity is lesser. So if the patient are presenting with weight gain, so weight gain is lesser. Dryness of skin is just little bit mild dryness of skin is there. So they are lesser. Even the many of the patients are asymptomatic with subclinical hypothyroidism. They don't have any kind of symptoms, but when testing we are doing because of some diabetes or some other disease, at that time we detect that the patient is having high side of this TSS value. So subclinical hypothyroidism can be mildly elevated TSS value like in between 4.2 to 10, or it may be markedly elevated TSS value like more than 10. So if it is more than 10, then it is known as severe subclinical hypothyroidism. Otherwise, it is known as subclinical hypothyroidism, where the T4 and T3 are normal. Next slide. So in the overt hypothyroidism, we see TSH value is more than 4.2, but T4 and T3 value are lower than the normal. But in subclinical, T4 and T3 are normal, but TSH is still raised. Next slide, please. So we see the subclinical hypothyroidism. It is the biochemical entity is there. We don't have, if the many of the patient don't have the symptoms, then the question arises whether we should treat or not treat such kind of the patients. Next slide, please. So yeah, so this is the epidemiology of subclinical hypothyroidism in India. So this varies in various studies. Somewhere it is 8%, like Dr. Unikrishnan et al. He has done a study in southern part of India, particularly in Kerala. So where it is around 8%. Dr. Marwa et al. Have seen in Delhi or adjacent area it is around 19.3%. So again, Unikrishnan has done again another study. It is around 9.4%, and then Dr. Abraham and Sahu et al. They have done this study. So they have seen the prevalence is in between 20 to somewhere it is around 5%. Next slide, please. So this is the natural course of subclinical hypothyroidism, where the TSS rises and the T4 started to fall. Somewhere, somewhat it is a normal limit. Earlier, then later on it falls. So in many of the patients, we know this subclinical hypothyroidism reverted. So it reverted to euthyroid state in normal state in 60% of the patients over the 5 years. But somewhere it is course is different. So in 1 to 5% patients each year, it is converted in case of overt hypothyroidism. Next slide, please. So in whom it is converted to overt hypothyroidism, particularly in those patients who are having anti-TPO antibodies. So if they are autoimmune thyroid disease they have, in those patients it is converted to overt hypothyroidism. So how actually the subclinical hypothyroidism is asymptomatic, then why to treat, why it is the entity they have made. So they are having some deep effect on the cardiovascular system, cholesterol, and some other system also. We can say neurological systems, some psychological problems can be there. Next slide, please. So now it is associated, how it is associated with cardiovascular system. So whereas a study have shown it can worsen the heart failure, or patients may present with heart failure with subclinical hypothyroidism. Again, it can present with coronary artery disease, or it can present with some atherosclerocardiovascular disorder. So atherosclerosis is aggravated because of subclinical hypothyroidism, or heart failure may be aggravated because of subclinical hypothyroidism. Next slide, please. So this is the meta-analysis of the study. They have shown that if you are not treating the subclinical hypothyroidism, so mortality is more, heart failure is more. Now come to subclinical hypothyroidism and this cardiovascular consequences. Again, so hypertension is more when the TSS rises. Dyslipidemia is more when TSS rises. Endothelial dysfunction is more when TSS rises, which again causes atherosclerosis. Then atherosclerosis is more when TSS rises. Heart failure is more when TSS rises. Cardiac arrhythmia also increases when TSS rises. Obviously, cardiovascular mortality is increased with rising of TSS value. Next slide, please. So these are various effect of this rise in the TSS value. So again, the other thing is that many of the patients who are presenting with subclinical hypothyroidism, they are having some fatigue, lethargy, or dryness of the skin, or alopecia can be there. Such kind of symptoms can also be there with subclinical hypothyroidism. Next slide, please. So now again the treatment algorithm for the subclinical hypothyroidism. So in subclinical hypothyroidism, if the patient is child, we can consider the treatment. Then the patient is at the older age, we can consider the treatment. If the patient is having some cardiovascular disease, if patient doesn't have cardiovascular disease, then we need not to treat the subclinical hypothyroidism in older age. If the TSS value is more than 10, then we have to treat the patient. If the TSS value is in between 4.2 to more less than 10, then if the patient is anti-TPO positive, anti-TPO antibody is positive, then we should consider the treatment. If it is negative, then we can just monitor the symptoms, or we can monitor the this test, thyroid test. So these are the various indications of the treatment of subclinical hypothyroidism. First thing, if the patient is symptomatic with subclinical hypothyroidism, then we have to treat the patients. Patient is presenting like depression or some irritability or anxiety or like that, then we have to treat the patient. Next slide, please. So now in elderly population, if we see the subclinical hypothyroidism they are presenting, so what to do in those patients? If the patient is around 75 years or more than 75 years, then we can just observe the patients. If the patient presenting with subclinical hypothyroidism, if obviously the TSS is more than 10 and the age is less than 75 years, then we have to treat the patients. If the age is more than 75 years and TSS is more than 10, then we have to take some individualized decision on the patients. If the patient is having some cardiovascular disease, then we have to treat the patient. If patient doesn't have cardiovascular disease, then we can observe the patient, or we can just do the repetitive testing of the patient. Next slide, please. Next slide, please. So now, next slide, please. I'm not going in such minute detail of this subclinical hypothyroidism. Next slide. So what you need to know in thyroid, particularly hypothyroidism. So thyroid hormone should not be routinely offered to the adult with subclinical hypothyroidism. Okay, treatment is always individualized in case of subclinical hypothyroidism. Taking a pill and just attending the periodic testing and ongoing lifelong basis is very burdensome for the patients. Okay, the pill burden is also a big thing. Otherwise, obviously expenses are also higher. If you are considering that this levothyroxine is very cheap, it's very inexpensive medicines, but we should consider the pressure on the healthcare system, how the patient are gathered in the hospital, and their expenses of transportation is also there. The time which they are giving for their consultation, that is very important. Otherwise, they would have done something productive for the country. So we should think of that one also. We know the thyroid hormone doesn't lead to any important benefit in adult with subclinical hypothyroidism. In some quality of life, sorry, or some weight reduction. It is not that we don't have the data that if we are starting the levothyroxine treatment in the patients with subclinical hypothyroidism who are obese, we don't have the data that it will decrease the weight. No, it will not decrease the weight. Weight can be decreased only by decreasing the diet, nothing else. Next slide, please. So if we see the hyperthyroidism pregnancy, it is very important topic, particularly for the patients who are pregnant. Next slide, please. So again, overviewing hypothyroidism pregnancy is very common disorder. We should routinely check any female who are just planning for the pregnancy. At that time, we should check this thyroid status of the patients. So this is the prevalence of hypothyroidism, major 11 cities in 9 states of India. So it is very common, it is not uncommon. Next slide, please. So we know that pregnancy is a natural, stress on the thyroid, this gland. Obviously, thyroid gland requires the more production of the this T4 and T3 hormones because of the estrogen in pregnancy is increased. So again, TBG is increased. TBG is thyroid hormone binding globulin. So it bonds to the thyroid hormone. So free thyroid hormones can act only on the receptors. This bound hormone cannot act. So once the TBG is increased, then thyroid gland has to produce more hormone to bound the TBG. So again, the similar changes because of the HCG. HCG is secreted from the placenta and the fetus. So again, HCG stimulates the thyroid gland to produce the T3 and T4, just like TSH stimulates the thyroid gland on the same receptor it acts because they are having the same this alpha chain. Then peripheral metabolism of this thyroid hormones is increased. So we require the more thyroid hormones during pregnancy. So the gland is stressed and it causes the hypertrophy of the thyroid gland. So thyroid gland is enlarged during pregnancy because of the production of the more thyroid hormones. Next slide, please. So if we are considering the Indian guidelines on the management of maternal thyroid disorders, so thyroid hormone requirement increase in tune of 30 to 50% during the pregnancy. Next slide, please. So what we say in our patients who are planning for the pregnancy and their hypothyroidism, they are taking some certain amount of tablet, we say you increase the tablet in tunes of 25 microgram to 50 microgram once you get pregnant at that time. So then you need to increase the dose of levothyroxine during pregnancy. Next slide, please. So again, all the pregnant female should be screened during the first antenatal visit for the TSH level, whether it is more or it is less. If it is more, then we need to treat the patient. Next slide, please. Because for the first trimester, when the fetus start to secrete his own hormone, till that period, fetus is dependent on the maternal thyroid hormone. And you know, the first trimester, first 3 months are very critical for the fetus brain development. So if the maternal side, if the patient is thyroid hormone deficit, then obviously the IQ will be lesser in the fetus, in the upcoming kid. So these are various guidelines. So what should be the ideal TSH level in the patient who are pregnant? So in the first trimester, this ITS guidelines, they are saying in first trimester it should be around 2.5 and second 3 and third also 3. So these are the previous guidelines, but this time ITS, this ATA guidelines, particularly ATA, they are saying, American Thyroid Association is saying, if it is less than 4, then it's okay. If it is more than 4, then only we need to treat the patients. Otherwise, we need not to treat the patients. Otherwise, in ITS guidelines, Indian Thyroid Society, they are saying it should be quite lesser. Or some ETA, European Thyroid Association, also saying, just like Indian Thyroid Society, it should be a little bit lesser. Next slide, please. So if we consider the treatment in the patient, particularly in the Indian scenario, what we do from our side, if the patient is having TSH more than 4, we treat the patients. If the patient is having TSS in between 4 to 2.5, then we go through the anti-TPO level. And if the patient is symptomatic, then we treat the patients. If the patient is less than 2.5, then we don't treat the patient. Or if the patient is already on the levothyroxine therapy, then we increase the dose of levothyroxine in the tune of 30 to 50%. Next slide, please. So this already I've explained. If the TSS is more than 4, then obviously we need to treat the patients. If it is less than 4 and still anti-TPO positive and more than 2.5, then we need to treat the patient. Next slide, please. So again, the postpartum management. Then during the postpartum, we see the patients to take the same tablet as they were taking before the pregnancy. We reduce the dose after delivering of the baby. Next slide, please. So to summarize these all things, this is overt hypothyroidism, subclinical thyroid hypothyroidism, or hypothyroidism during pregnancy. We have summarized these all things, symptoms, testing, and when to treat the patient and how to treat the patients. So now we can go through the hyperthyroidism. So again, the one part is hypothyroidism, when the synthesis and secretion of thyroid hormone is lesser. Then other side is hyperthyroidism, when the synthesis and secretion of thyroid hormones is more than requirement. So that is not hyperthyroidism. So doctor, can you upload the next part of slide?
Yes, sir. Yes, sir. Yes, sir. I'm just. इधर बोलो. Sir, slides are visible, sir?
Yeah, slides are visible. So now we are going to the hyperthyroidism. So first we start with some case report. Next slide, please. So hyperthyroidism more, it's the higher secretion of the this thyroid hormones. So first case presentation. So the 31-year-old female presented with complaints of fatigue, dizziness, nervousness, anxiety, occasional palpitation, weight loss since 4 to 8 weeks. There's no history of neck discomfort or dysphagia, no shortness of breath, cold or heat intolerance, no ocular symptoms like burning, itching, tearing, diplopia, they are not there. No reported history of radiation to the neck or exposure to some excess iodine. Next slide, please. So if we go through the past history, that is uneventful with the patients. Previous one can do slide. Yeah. So the patient currently, she doesn't have any kind of medications like contraceptive pills or some thyroid medications. Patient contemplating pregnancy after 2 years. Then if you go through the family history, patient's mother has history of Hashimoto thyroiditis and hypothyroidism, and she was on levothyroxine replacement therapy. No history of hypertension, diabetes, or coronary artery disease with the patient. Next slide, please. So on clinical examination, if we see the temperature is 37.6, that is fairly normal. Blood pressure is 140 by 80. So here in blood pressure, the pulse pressure is higher. It is around 60, so it should be in between 30 to 40, but it is 60, so it is high. Pulse rate is 110, so tachycardia is there. Pulse rate is still regular. Respiratory rate is 16, that is fairly normal. Presence of fine tremors on hand. Then skin examination, skin is warm and moist. Thyroid gland is non-tender, diffusely enlarged without palpable nodules, or some bruise is also present on the thyroid gland. No cervical lymphadenopathy, no peritibial myxedema is present. If we go through the ophthalmologic examination, that is fairly normal. No exophthalmos is there. Pulmonary and abdominal examinations are also normal. So what laboratory test would you consider based on such clinical examination? Obviously, we go through some thyroid function testing. So here, the complete blood count is absolutely normal. All values are normal. If you go to the free T4, here it is normal. So we don't have some thyroid disorder. Again, free T3 is 3.3. It's little bit higher. If you go through TSS, so TSS is lower. It is suppressed. So TSS is suppressed. This is the abnormality in the patients. If you go through serum beta HCG, so fairly it is negative. So patient is not pregnant. Radioiodine uptake, if you go through the uptake study, it is around 60% at 24 hours. So it is very high. So radioiodine uptake is high in this patient. TSH is suppressed in this patient, and T3 is just a little bit high. So in sonography, if you go through the this ultrasound, so diffusely, heterogeneously, enlarged thyroid gland is there, or increased Doppler flow is there. So blood flow is increased in a large thyroid gland. Next slide, please. So considering these all investigations, so what should be our diagnosis? Next slide, please. So it is diffusely enlarged thyroid gland with hyperthyroidism. Particularly, it is subclinical hyperthyroidism with you go through the Doppler. So Doppler is showing this higher blood flow, and thyroid scan uptake is around 60%. That is very high. So obvious diagnosis obvious in this patient, that is Graves' disease. So the syndrome, hyperthyroidism is a syndrome of hypermetabolism resulting from the excess quantity of thyroid hormones. It may range from subclinical hyperthyroidism to life-threatening thyroid storm. So major etiology, if we consider, it is most common is Graves' disease, that is autoimmune hyperthyroidism. Then toxic multinodular goiter. So there are many nodules are there in thyroid gland. Those are secreting higher amount of thyroid hormone. Then solitary toxic adenoma. Then thyroiditis. So during thyroiditis, thyroid gland destruction is there. So we see the release of thyroid hormone is there, but not the formation or synthesis of hypothyroid hormone, but release of preformed hormone is there in case of thyroiditis. Next slide, please. So if we go through the symptoms of hyperthyroidism, so symptoms are hyperactivity, irritability, dysphoria, or we go heat intolerance is there, and thyroid swelling is there, sweating is there, increased sweating, palpitation, then fatigue, weakness, weight loss is there, and still increased appetite is there. One side we consider the weight gain in spite of decreased appetite, but here weight loss in spite of increased appetite is there. And obviously hyperdefecation is there, not the diarrhea, hyperdefecation is there. Polyuria can be there, oligomenorrhea or some menstrual irregularity is there, loss of libido is also there. If we consider the signs, then tachycardia, atrial fibrillation, tremors in hand, enlarged thyroid gland, warm and moist skin. Also, these are various symptoms like muscle weakness, particularly proximal muscle weakness is there. Next slide, please. So these are various manifestations in the individual symptoms system, like cardiac manifestation, palpitation is there, premature atrial contraction or ventricular contraction can also be there, sinus tachycardia, high cardiac output, and atrial fibrillation can be there in particularly elderly patients. If you go through the ophthalmic manifestations, then here 20 to 40% of the patients with Graves' disease may present with chemosis, conjunctivitis, or mild exophthalmos. Then go to the skin these manifestations. Around 3% of the patients with Graves' disease, they present with pretibial myxedema, can also be there. Next slide, please. So again, the thyroid acropathy is there. So thyroid acropathy is known as some clubbing of the fingers or some dirty nails can also be there. And this is also considered as an autoimmune disease. Then hypokalemic periodic paralysis. This is not very common, but particularly in the Asian population, it is very common. Next, gastrointestinal manifestations like weight loss, hyperdefecation, and abdominal pain can be there. Next slide, please. Then if you go through the neurological manifestation, then rapid mentation, agitation, restlessness, confusion, delirium. Then in many of the patients, when they are present with thyroid storm, obtundation and coma can be there. Myopathy is there, particularly proximal myopathy. Then hyperactivity is also there. Fine tremors or some rarely periodic paralysis, as we have already explained. thermoregulatory system, if you're going, so warm and moist skin is there. Opposite to the hypothyroidism, there the dry and cool skin is there. Then increased sweating, heat intolerance, hot flashes can be there in some patients. Next slide, please. So these were various systemic manifestations of this hyperthyroidism. If you go through the subclinical hyperthyroidism, so here the TSS value is lesser, but still T3 and T4 are normal. So all the clinical features of hyperthyroidism, overt hypothyroidism, we can say, are mildly presented in case of subclinical hyperthyroidism. Prevalence is less than 2% in adult or elderly population. Then causes, again, they can be Graves' disease, toxic medullary goiter, thyroiditis, or some solitary thyroid nodule. So they are also associated with increased risk of atrial fibrillation and also osteoporosis, in particular elderly patients. Then treatment, again, we go through some beta blockers, or we can use the anti-thyroid drugs depending on the etiology of the subclinical hyperthyroidism. Next slide, please. So diagnosis depends on the this thyroid function testing. If the TSH is suppressed, T3, T4 more than the normal, then it is overt hyperthyroidism. If TSH is suppressed but still T4 and T3 normal range, then it is subclinical hyperthyroidism. We go through the measurement of TSH receptor antibodies, that is known as TRAB. So if TRAB is positive, then it is Graves' disease. If it is negative, then it may be something else, maybe some toxic nodal goiter or something else. We go through the ultrasound. If ultrasound is showing some nodules, then it can be toxic multinodal or toxic nodule goiter. Next slide, please. So again, if we require in some patients when the diagnosis is not met, at that time we can go through the radioiodine uptake study. So in the scan, if it is diffusely uptake is there, it is Graves' disease. If it is multiple nodules are there, multiple islands are there, then it can be toxic medullary goiter. If single nodule is there or some adjacent area suppressed uptake is there, then it can be toxic nodule. Next slide, please. So now indication of anti-thyroid drug treatment in the patients, any patients who are having clinical or overt hyperthyroidism. Obviously, in those patients who are not because of thyroiditis, or they are having some multinodular goiter or hyperthyroid because of that multinodular goiter, or some Graves' disease or toxic nodule, in those patients we need to give anti-thyroid drug. In elderly patients with some other comorbidities, but still they are having subclinical hyperthyroidism, then also we need to treat the patients. In young patients, subclinical hyperthyroidism, we can observe the patients only on the beta blocker. Next slide, please. Now, indication of radioiodine therapy. In the female patients who are particularly planning for the pregnancy, in those patients we can use the radioiodine therapy. But after radioiodine therapy, till 6 months, patient should be prohibited, should use some contraceptive pills, because they cannot plan the pregnancy for 6 months after getting radioiodine therapy. In some individual with having some comorbidities of surgical risk, and the patient cannot take the anti-thyroid drug because of some serious this adverse effect or some skin reactions like that, then we can give the radioiodine therapy. In most of the patients, we usually give the radioiodine therapy who are not getting treatment, not getting relieved even after 1 to 1.5 year of anti-thyroid drug therapy. In those patients, we usually give the radioiodine therapy. In some patients where the Graves' ophthalmopathy is there, that is more. So considering the aggravation of ophthalmopathy because of this radioiodine therapy, we can go for this surgery. Next slide, please. So indication of surgery. So we have the 3 modality of treatment in case of hyperthyroidism. First is anti-thyroid drug, then second is radioiodine therapy, third one is surgery. So in surgery, we do in limited patients when the large goiter is there in the patient. At that time, we can plan for surgery. Or in some patients when we are suspecting some thyroid malignancy also, and that time also we can do some this thyroid surgery we can do. Or in patients with large non-functioning photopenic or hypofunctioning nodules are there, at that time also we can consider the surgery. Or in patients who are pregnant, already pregnant, so in those patients and they are not controlled with anti-thyroid drugs, in those patients we can consider the surgery. Next slide please. So now these are various contraindication for the all three modalities, like anti-thyroid drugs, any non-reaction, or for the radioactive pregnancy, lactation, or suspicious of thyroid cancer, or the patients are having some contraindication according to radiation safety, or female planning to pregnancy within 6 months. And contraindication for the surgery, substantial comorbidity like older age, cardiopulmonary disease, or end-stage cancer like that at that time also. Next slide, please. So now thyrotoxicosis management. So we have the anti-thyroid drugs like methimazole, carbimazole, and propylthiouracil. So propylthiouracil we use only during the first trimester of pregnancy. Otherwise, use carbimazole or methimazole. This carbimazole is the prodrug of methimazole. So if methimazole we use in the tune of 10 milligram, then carbimazole we use in the tune of 20 milligram. So the difference of 1.2 ratio is 1:2 is there. So they inhibit the formation of thyroid hormone by interfering with the incorporation of iodine into the tyrosyl residue of thyroglobulin. So they inhibit the coupling of this iodotyrosyl residue from the thyroglobulin. So again, the dose is 30 milligram methimazole or this 40 milligram once daily. We start with thrice daily, then we can go through the once daily after 1 month. So adverse effect, mainly the skin reaction can be there. If it is severe reaction, when severe reaction we consider when the skin reaction is there in the oral cavity, some mucous membrane, oral cavity, eyes is also involved. At that time it is severe skin reaction. At that time we need to stop the anti-thyroid drug. We cannot start again the anti-thyroid drugs. Or if it is some bone marrow suppression can also be there when the patients are presenting with this neutropenia, or they may present with some high-grade fever or sore throat. At that time also we have to stop the drug. Or in many of the patients we need to give factors to raise the WBC or neutrophils. So these are various side effects of this anti-thyroid drugs. Then iodides, if you are considering, iodide can also be given in some patients to control this hyperthyroidism just before we are planning for this surgery at that time. Next slide, please. So in iodides, there can be some escape phenomena. It can be given for 1 week or maximum for 2 weeks. After that, during 2 weeks, we have to go for the surgery in the patient. Otherwise, patient will go through the escape phenomenon. Much more this thyroid hormone synthesis will be there with the iodine. Next slide, please. So now the third one is radioactive iodine. So it can be given in the thyroid patients, can be given like in between 10 to 15 microcurie, or we are making the patients hypothyroid after giving this radioiodine. We are making him hypothyroid, then we start the levothyroxine in the patient. So anyhow, he has to take the medications, but this anti-thyroid drug we cannot give more than this 1.5 year. Next slide, please. So adjuvant therapy we need to give in the patients, because if we are giving the anti-thyroid drugs or radioactive iodine, they will not act immediately. They require some time to work. So during that period, we require some adjuvant therapy like beta blocker to control the thyrotoxic symptoms. So beta blocker we can give propranolol in the dose of 40 milligram once daily or thrice daily or 4 times daily. Maximum dose we can give up to 240 milligram. Or calcium channel blocker also we can give the patients are having some COPD or chronic smoker, or we cannot give the beta blocker because of some contraindication at that time. Diltiazem we can give in the dose of 60 to 120 milligram 4 times daily. And also in some patients, very rarely we can give dexamethasone also, steroid. In some severely thyroid toxic patient, when the thyroid storm is there, this steroid decreases the conversion of the T4 into T3. And also propranolol also decreases the conversion of T4 to T3. So patients symptomatically, they get the benefit. But all the symptoms are not controlled with these beta blockers. Next slide, please. So in first patients in which we have presented just a few minutes ago, the typical presentation of hyperthyroidism was there. So diagnosis in that patients, we have made the Graves' disease because of homogeneous radioactive uptake was there, and it was increased up to the tune of 60%. No nodule was found on the ultrasound, and also on the Doppler, increased blood flow was there. TSH was suppressed, undetectable, and T4 was, in that patient, it was little bit normal. T3 was raised. So it was obviously Graves' disease, but subclinical hyperthyroidism was there. Next slide, please. So for this patient, the treatment options are radioiodine therapy, surgery, or anti-thyroid drugs. So as the patient was mildly it was subclinical hyperthyroidism. So we started with methimazole therapy in the dose of 10 milligram daily. Then advise the routine monitoring of T4, T3, and TSS until the patients become biochemically euthyroid. Then subsequently we test to performed every 4 to 8 weeks to just titrate the dose of this methimazole therapy. Then next slide, please. So now come to the hyperthyroidism pregnancy. So I think our time is over around 4 p.m. So I'm just giving some overview of hyperthyroidism in pregnancy. So particularly if the hyperthyroidism is there in the pregnancy, we should consider whether it is normally or it is some abnormal. Because of normally in pregnancy, TSH is suppressed. And also T3 and T4 hormones are raised in normal pregnancy in the tune of 1.5 times the normal. So they are raised in TSH suppressed. So we misdiagnose the patient of normal thyroid functions with the hyperthyroidism in pregnancy. So that should not be there. Next slide, please. If the patients are presenting with the hyperthyroidism, we should go thoroughly investigate the patients. If the patient is having really hyperthyroidism like Graves' disease or some multinodal goiter like that thing they are having, then in the first trimester, we can use the PTU, propyl thyroid cell drug. Then second and third trimester, we should use carbimazole or methimazole because propyl thyroxine is very toxic. It can cause fulminant hepatitis. Then if the patient is considered for the surgery, then in second trimester, we can do the surgery. As a propranolol is the drug we are using for the hyperthyroidism, it should not be used in pregnancy. And iodides also cannot be used in pregnancy. They can lead to fetal hypothyroidism. So we have left with one drug, this antithyroid drug, and surgery in second trimester. Radioiodine cannot be done in the pregnancy. Next slide, please. So these are various recommendations that I already explained you. Next slide, please. If the patient is not pregnant and they are hyperthyroid, then first make them euthyroid or first do the definitive treatment of hyperthyroid, then ask the patient to get pregnant. Next slide, please. So we consider the TRAB thyroid receptor, this thyroid TSH receptor antibody testing pregnancy at the starting of pregnancy. Then repeatedly we need to check the patients if it is symptoms of thyrotoxicosis increased, or at the 30th week of the pregnancy, or during the delivery, like that we can check the patients. Next slide, please. So regularly we check the patients at least at 4 weeks. Then we titrate the dose of this anti-thyroid drug in these patients. Once during pregnancy, patient can become euthyroid if they are already hyperthyroid. If they are hyperthyroid, it can worsen or it can normalize, or it may be the same like that during pregnancy. But in the many of the patient, it is usually in most of the patients, it is decreased. The hyperthyroidism severity is decreased during pregnancy. Next slide, please. So again, the cardiovascular effect, we have already explained the cardiovascular system. So now I'm just ending my presentation, just concluding this all the thyroid disorder, which any questions if are there, then obviously I'll take those questions. Now over to Dr. Malashri.
Thank you so much, sir. Thank you so much for enlightening us with your very knowledgeable and very scopeful presentation. As we know, along with the understanding of pathology, it's important to give special emphasis on thyroid condition diagnosis. I extend my heartfelt thanks to Dr. Sanjay Saran, sir, for delivering such a wonderful guest lecture on the event of national webinar on this thyroid disorders. Thank you so much, sir. Sir, is it possible for you to stay for some more, few more moments to share some queries our participants have, sir? Is it possible for you, sir? Few more moments.
Go ahead with the questions some have asked, no? Some questions
yes,
have been
ma'am.
asked.
Yes, ma'am. Sir, actually, already you have mentioned in the webinar, you have mentioned already like no diet restrictions. Few of our participants, they have asked a few questions regarding diets, like whether the diet which are rich in fat or fatty acids, like that diet also we no need to restrict if they are taking any thyroxine supplement or not, like that they have raised a query. I just would like to get answer from you.
Yeah, dietary restrictions are not there with thyroid disorders. Whatever the patient is getting, they can get now. So if fatty diet or like that they are getting, it's a general as a whole restrictions is there for the fatty diet because it increases they will cause the weight gain or some other cardiovascular disease or some other disease, because obesity is a very big epidemic in India. So many diseases are there because of some obesity. So fatty diet is restricted as a whole, not in thyroid disorders. Thyroid disorder, we can give whatever the patient would like to take, he can take now. We are saying the patient not to take the dietary fat because of the fear of increasing weight gain, because of that only.
Yes, sir. Thank you so much, sir. I think our participants got a clear answer for that. And sir, one more query is there. The surgical recommendations are not indicated, but if it is threatening to fetus, it's this question I have received from gynec department, sir. If the hyperthyroidism symptoms are like more severe, so if one with the medicine, with the hormonal replacement therapy also, if they are getting more symptoms, then how we have to proceed, sir? Whether a termination of the pregnancy is most acceptable, or any other solutions we can go for, sir, during second trimester, sir?
Yeah, actually, if the patients are symptomatic or they are just severely hyperthyroid, or if they are not controlled with drug, at that time we can go through the pregnancy with judicious use of some other drugs also, like beta blocker and a calcium channel blocker. We can go for surgery in second trimester particularly. In first trimester we cannot go for surgery, and in third trimester also surgery is not advisable for the patients. Even if the patient is symptomatic and it is life threatening, they can then we can go through the this abortion, then we can go through the definitive treatment in those patients when the life threatening is there. Otherwise, in most of the patients, we can manage with anti-thyroid drug therapy.
Thank you so much, sir. Sir, finally, one more question is there for you. In cases of subclinical hypothyroidism, many of the time, accidentally patients will get diagnosed like they may be undergoing any other surgery or a routine health checkup. They will be diagnosed with a subclinical hypothyroidism. So in that condition, patient anyway they don't have any symptoms. But how about the management? We have to go for only diet and yeah, or sorry, diet and exercises, or we have to go for hormonal replacement therapy even though they don't have any symptoms.
Yeah, in subclinical hypothyroidism, we see if the patient is already having some cardiovascular disease or some other disease, then we can consider the treatment. If the patient is anti-TPO positive, if the patient they are having some anti-TPO report, or we can advise them anti-TPO the testing. If it is positive, then we can consider the treatment. If the patient is child and anti-TPO positive, then also we can consider the treatment. So there are certain indication of the treatment in subclinical hypothyroidism who are asymptomatic. If goiter is there, then also we can consider the treatment of the patient.
Yes, sir. Thank you so much, sir.
Thank you so much, sir. I'm very thankful that both our speakers have presented their presentation in a very elaborate manner, critically explaining all the facts and clinically dealing with so many conditions. Dr. Arun Chowgle sir and Dr. Sanjay Saran, I thank both of you for this wonderful presentation. Before that, sir, I have a few questions. You were saying that in your presentation that in subclinical hypothyroidism, there is no need to give thyroxine supplementation. Is it true, sir?
Yeah, subclinical hypothyroidism, as I already explained, we have a certain indication for the levothyroxine therapy. Otherwise, supplementation, there's nothing like supplementation. We can just give the thyroid replacement therapy if it is indicated. If the patient is anti-TPO positive, or if the patient is pregnant, or patient is having some cardiovascular disease, or the patient is having goiter, or the patient is symptomatic. At that time, we can consider the treatment of levothyroxine therapy.
Okay. And one more question to Dr. Sanjay Saran. I think sir is there online. And I would like to ask one question on whether in subclinical hypothyroidism, can we go for Ayurveda therapy, or is it a must that for any type of hypothyroidism we have to give supplementation with thyroxine?
Actually, it is very tricky question. It's very difficult to answer. Actually, I do not know anything regarding Ayurveda therapy.
No. This question is for Dr. Arun Chowgle, sir. Because we have so many patients who have hypothyroidism. Like, till how many years we can continue this, sir? Like, is there any fixed? We can go for 3 years or 4 years, then check the level, then we can stop the medication, or it has to be taken lifelong. That is what my query is.
Yeah, on the regular basis, we have to go to the thyroid function testing. Okay, if the testings are permitted us to stop the therapy, then we can only stop the therapy. Otherwise, we cannot stop the therapy on the symptomatic basis. Only we stop the therapy on the testing on the level of those thyroid hormone, TSH, T3, and T4.
Like whether we should stop the medicine for some time and wait and watch and then go for the testing, because whenever we test it will be normal. So we get this idea that it is because of the medication. So whether we stop the medication and then check.
Yeah, no, it is not recommended that in any patients who is getting medicine because of some disease, or we are stopping the treatment to check whether it is normalized or not. So we go through the testing, thyroid testing. If they are suppressed, then we can decrease the dose or we can stop the therapy. Otherwise, in the normal patient, we cannot stop the therapy. And sometimes, like if we see the many drugs are there, those who are life-saving drugs, in those patients, those type of drugs also, we cannot stop the therapy. So in the medical science, it is not there that you stop the therapy and check whether it is normalized or not. Now, if it would be normalized, then obviously it would be shown in the testing report that it is now suppressed because of levothyroxine therapy. So we can decrease the therapy or we can stop the treatment. So such kind of practice is not recommended
Any inputs from Arun Chogle sir regarding this question?
Yeah, madam.
Yes.
See, we are practicing where patients having subclinical hypothyroidism, where T3 is normal, T4 is normal. TSH, we are keeping range, some range. If TSH is more than 5, up to 20. Uh, Up to 20, we are not recommending any thyroxine supplements. We are asking the patient to go for change your lifestyle and change your diet. Along with that, we are practicing with the Ayurvedic medication. This is the routine phenomena in our day-to-day clinical practice. Up to 20, we are having some limit. TSH up to 20, we are treating without the thyroxine supplements. But condition is the T3, T4 values must and should be normal.
I think the 2-3 questions are there from audience side, so you can ask that question. Someone wanted to know the levels of TPO normal levels. TPO.
Empty TPO normal, I think it is less than 60, I think so.
Achha.
Less than. I don't exactly this one.
Any questions?
So I have a question.
Yeah.
Can I put forward a question to Sanjay
Yes,
sir?
yes, Sumia Javed, you can.
Sir, I wanted to ask, suppose as we discussed in one of the sessions that patients with rheumatoid arthritis also generally have a coexisting thyroid. In such a condition, how would we manage giving them thyroid supplements? So what would be your approach to such a patient who's a known case of rheumatoid arthritis and an hypothyroidism case?
Yeah, because of both of the conditions are autoimmune, so it is frequently many of the hypothyroid patient or many of the rheumatoid arthritis patients are presenting with these thyroid disorders. So it is so obviously the treatment is same as we are giving in hypothyroid patients, but only the thing is that the tablet should be taken empty stomach and other tablets should be taken later on, at least 4 hours after taking the this levothyroxine tablet. Or if it is
So like you gave the instructions. So, but then suppose in these patients, if you routinely get thyroid levels checked, and if the thyroid levels are absolutely normal, all T3, T4, and TSH, and they are on a minimal of 25 micrograms dose, say for example, should we consider to stop the drug, the supplement, or should we continue to give the thyroxine?
No, we have to give the tablet now. We should not stop the tablet now. Once the thyroid hormones are suppressed, then only we can consider to stopping the tablet now. Otherwise, we cannot.
How would we identify the suppression of thyroid hormones on the lab results?
When we see the T3 and T4 are increased in our this thyroid function test, or TSS decrease at that time only, we can just stop or decrease the tablet now.
Okay, so this is like a subclinical presentation.
Yeah.
In a way. And then you evaluate the symptoms and the patient does not show any thyroid symptoms and you just see raised values and we can stop. That's what you're implying?
Yeah. So it is individualized. It is not the as a one phenomena for the each and every patient. We know the diversity of thyroid disorder, and there are many different kind of thyroid disorders are there. Many times we see the funny thyroid function testings are there. Somewhere some TSS is decreased and T3 is decreased, T4 is also decreased. Somewhere these all are increased. So somewhere obviously very funny, like TSS is decreased, but T4 is also decreased, but T3 is increased, like that now. So it is very different in many kind of the patients. So we cannot apply the one thing on the each patient. It's very
common. Correct. Yeah. So you treat accordingly.
Yeah, accordingly as the treatment individualized. So a lot of etiology are there for hyperthyroidism, or many etiology are there because of hypothyroidism. Once we mistreat the patients, misdiagnose the patient, then again some problem can occur. No? So many of the patients of thyroiditis are there and they are considered as a hyperthyroidism. They start the treatment of hyperthyroidism. Then eventually, after a few weeks or few days, they become hypothyroid. Then we start the treatment of hypothyroid. Then eventually they become hyperthyroid. So such kind of conditions we usually see our clinical practice. So treatment is
Yes,
individual
sir.
depending on the particular etiology and diagnosis of the patient. So again, I have to
Right.
leave for the meeting. I have to go in another meeting. Actually, I was in meeting in SMS. Then on the way, I stopped here some in hotels. I'm presenting from an hotel. Now I have to leave for my home. Then again, I have to be in the meeting after 30 minutes. So I have to leave.
Yes,
So,
sir. Thank you so much for.
Sir, thank you so much, sir.
Thank you so much. You can leave. We'll continue this.
so thank you.
Thank you, sir.
Yeah, have a wonderful day.
Thank you. Sir, one question is there to Dr. Arun Chowgule, sir. Sir, what is the relief if we use Nasya, whether it gives a short-term relief or it has a long-term relief? We can give
Sir.
one course of Nasya, then we can wait for some days and then we can give the second. So whether the relief will be there for a long time?
Madam, frankly speaking, I never practiced Nasya in thyroidism. Okay. That's why it is the authority of you people. You have to mention.
Yeah, we will just
Which type of Nasya is beneficial in hyperthyroidism, hypothyroidism. Just I as Urdu Chitragatavkara. Still, we are not planning for Nasya. We are only concentrating on Shamanoshadis in day-to-day clinical practice.
Yes, sir, we will take up
Frankly speaking, I never practiced Nasya in the management of hyper and hypothyroidism.
But the idea is very rational and definitely we will take up in future. So.
Yes, madam. Thank you.
For vote of thanks.
I have one last question.
Sumaya Javed ma'am, actually we are running out of time. Please put your message, your doubts in.
Last question we can. Malashri, last question.
Yes, ma'am. Yes, ma'am. Yeah, Sumaya ma'am, you can ask the question, ma'am.
Yeah, thank you, ma'am. Yeah, so this is, sir, I wanted to understand. So in the course, suppose a patient who's come to you and you've diagnosed him as hypothyroidism and he is taking the whatever management you might have decided, maybe giving him thyroxine supplement or maybe Ayurveda treatment. In the course of your treatment, maybe after a year or two, his levels might be normal. When you actually began the treatment, his anti-TPO would have been negative. But do you still think there is a possibility of his anti-TPO ever becoming positive in his lifetime? Is there such a possibility? You've seen such a case? Just want your inputs.
See what anti-TPO suggests. Anti-TPO suggests regarding autoimmunity.
Correct.
Am I right? Am I right?
Yes, sir. Yes, sir. Yes, sir. Definitely. Yeah.
Okay. If your immune level is go on disturbing, automatically anti-TPO values are go on increasing manner or decreasing manner normal. So that's why it is better to add immunomodulator for a lifetime for the management of raised anti-TPO levels rather than other line of management. It is just like that of rheumatoid arthritis. Okay,
Right.
your rheumatoid arthritis value, quantitative values are go on increasing and go on decreasing. Okay, it all depends on your immunity. That's why we call it as autothyroiditis. Okay, so lifetime you have either you have to ask the patient to go for the lifestyle or diet modification which enhance her or his immunity, or add some immunomodulator drugs like Guduchi, Amlaki, Ashwagandha Rasayana, like that. The Rasayana format, you have to continue. Okay?
Right, sir. Sure. Thank you, sir.
Thank you.
Thank you, Shamshaman.
Thank you, ma'am. Thank you so much, sir, for giving your valuable time. I request Dr. Pratima, for second year PG scholar, to give vote of thanks. Over to you, Pratima.
So, vote of thanks, sir. Will be. Hello, Pratima?
Yes. Good afternoon, Manirai. Saying thank you is more than good manners. It is a good spirituality. On the behalf of organizing team, it is my privilege to propose vote of thanks on this occasion. My sincere thanks to the patron of today's event, Sri Sarbananda Sonowal, Honorable Cabinet Minister of Ayush and Ports, Shipping and Waterways, Government of India. The heartfelt gratitude to co-patron Padma Shri Vaidya Rajesh Kotesa Sir, Secretary, Ministry of Ayush, Government of India. A heartfelt thanks and respect to the distinguished speakers of today's event, Professor Arun Chougule Sir and Dr. Sanjay Saran Sir, for gracing this occasion and enlightening us with knowledge on thyroid disorder despite of their busy schedule. We really owe you, sir. Immense thanks to the delegates who have joined us through various platforms. Without you, we would not have accomplished the success of the webinar. Gurau na prapyate yat tat na anyatrapi hi labhyate. Guru prasadat sarvam tu prapnoti evam na samshaya. We can gain anything with the grace of Guru. My heart goes out to thank the organizing chairperson of the webinar, the leading force for us, our respected Vice Chancellor, Professor Sanjeev Sarma sir, for his continuous support and encouragement. We are grateful to Professor Meeta Kotesa ma'am, Pro VC NIA Jaipur, for her constant support and encouragement. No event can take shape without a hardworking leader. A special thanks to the organizing secretary of this event, Professor Shamsha Fayaz ma'am, Professor and Head of the Department, Shalakya Department NIA. I extend my gratitude to the coordinators of this event, the respected faculty members of Shalakya Department NIA, Dr. Aparna Sharma ma'am, Dr. Gulabchand Kammal, Dr. Prabhakar Vardhan sir and Rajendra Soni sir for their visionary hard work and support to make this event a success. Moving on, I would like to thank all the teaching staffs of NIA scholars, NIA PhD scholars, PG scholars, non-teaching staff of Shalakya Department NIA Jaipur. My sincere gratitude to one and all who have involved directly or indirectly in organizing and running this webinar on thyroid disorders. Thank you, one and all. Over to you, Malashri ma'am.
Before we close, I would like to give a special thanks to the IT people who are not visible here, but they are doing their hard work and they are running this program. So special thanks to them for coordinating this program.
Yes, ma'am, absolutely. They deserve a thanks from our side, from our department. And thank you all participants. Thank you once again here with a great thanks and our gratitude to all. Your moderator, Dr. Malashri, PhD scholar, Department of Shalakyatantra, National Institute of Ayurveda, hereby officially announcing that webinar session is ended here. Thank you so much. Thank you so much for your presence. Thank you so much.
Thank you. We'll meet again.
Yes, definitely we'll meet again.
And e-certificates will be given only to those who fill the feedback form. Please
Yes,
write in the form.
Yes.
And of course, this session will also be live on YouTube and you can watch it anytime. Thank you.